very good evening to all of you. We are ready to start, and this time very unusually we are starting almost on time, and thank you all for being here in time so that we can start early, we can finish early for the single most important reason. We know all that, the football final. Okay, so on behalf of Lupin, EAU and USI, I welcome you all to EAU, the best of EAU 2018 Masterclass. I am Dr. Amit Bhargav, medical head of Lupin, and also I have a small family physician practice in Goregaon, Mumbai. So I would like to invite, the lights are too much, I can't see him. Mr. Rakesh Gupta.
Yeah, I'm here.
Oh, okay, because of the lights I couldn't see you, sorry. He's a senior general manager at Lupin, marketing and sales head, and he will brief you about the progress that Lupin has made.
Thank you, Dr. Amit. And definitely, I really welcome you all on behalf of Lupin Maxter. And I'm indeed welcome EAU, the faculty who has consented, and I'm really thankful to USI. Under their guidance, their support, this program is happening, and I can assure you this is actually the first of EAU. Last year we had Mike Kirby here and we had Masterclass 17. Times to come, the way we have really tied up with the USI and EAU will keep bringing these kind of programs, and we will see that ensure what best else can be done. I'm really thankful to local body here, East Zone. And let me tell you a little bit about Lupin. I had seen very closely Lupin. I have been part of Lupin for last 32 years. When Lupin was only 13 crore. Today it stands at $2.68 billion. And Lupin is truly, symbol of quality, a powerhouse of quality, and we have global footprints. I'll take you, I had been given, one or two slides. I'll run those through. This is a promoter, and DBG has founded this company in 1968 with mere 5,000 rupees. And today, we all know what Lupin is. Professionally managed company, and we are very clear in our vision. It's an innovation-led transnational pharmaceutical company, and we will continue to do that. As I said, that current turnover of the group is $2.55 billion. We are the fourth largest in US by prescriptions. This is a very big achievement for a company like of Indian origin, Lupin. If you see our international generic markets, we are the fourth largest in South Africa. We are the fifth largest in Philippines, sixth largest in Japan, seventh largest global generic market. In India, third largest Indian pharma company by global sales and fifth largest company in entire Indian market. Through the various years that we had really gone through very successfully, revenue today stands at of Indian domestic market 4,258 crores with a 11% growth, where we had hands down beaten the IPM. We have a very strong sales force, 6,800, 16 divisions, and we have mass marketing, one generic division, 14 medical specialties. Now, this is interesting. Actually, we have almost global position number 1 in chest. We were the first to launch all those TB drugs, and they have become a household names, AKT4, arsenics, all those kind of things. And cardio-diabetic, soon we will be number 1. Can I say, Dr. Amit, that? Yes, already we are number 2, number 3 kind of. That is, the commitment to you all. Urology is one such segment where we want to become, dream is not to be number 2 or number 3. Yesterday, I was discussing with Dr. Chappell. I was assuring him that you have to give your best, and we will give our best to our Indian doctors. And the association USI has given consent that they will continue and support us. really we want to become a real number one. It may take time, maybe 2 years, 3 years, we don't mind. And we would like to address the gap areas. We understand in urology, though we have, you can see a lot of products are there, but we feel that a lot of products needs to be introduced, which we will do times to come with your support, and we will see that we are there. Rest of therapy areas we have been doing very well, and we are committed to bring the best across therapy areas. Now, this is a time for me to once again call Dr. Amit and take you through the technicalities of the meeting, and he can have his own presentation. Thank you so much.
Okay, so before we go on to the main agenda of the meeting today, since we are meeting a lot of you for the first time, so just why is Lupin holding these meetings, and what is the thought process behind it? Just I promise it is not too many of slides, and a lot of them are very short slides, so I will not stand between you and the EAU faculty. Why did Lupin tie up with EAU? Very simple. As Mr. Rakesh Gupta has already told you, we have this new commitment to urology to fulfill whatever gaps there might be. And so this meeting, the ones in the other cities, the content, there is no tampering of the content, there is no product focus, there is no promotional focus, and obviously there is no profit focus. It's pure, simple academics. And Lupin being a healthcare partner, we realize the importance of information dissemination, and therefore we are facilitating the same. Coming to information, just having access to information is not enough. Well, there are a lot of steps between information and adoption in clinical practice. Information, to begin with, leads to interactions. There are a lot of discussions. Information also based on the experience of individual practitioners leads to their own analysis, and they gain insights from the information. Okay, this is likely to be useful to us. And these insights lead to further interactions with the people who have generated that data. So there's a lot of to and fro communication until a consensus is arrived at. And then it starts getting clinically relevant. So just some clinical trial which has come up somewhere, just because it is a randomized controlled trial, does not necessarily mean it is going to be clinically relevant to you or us. So once the clinical relevance is established, then it gets into guidelines and gets integrated into practice. So that's basically the flow that happens. So we are facilitating this step of information, insights, and interactions, so that with this great faculty from EAU that is here, you will have ample time to discuss with them, and the process goes on. There is a need to exchange experiences. We all know we have been students, we have acquired knowledge, we have become professionals, we have practiced, we have become successful. In fact, all of you sitting here are probably, it would not be inappropriate to say you are hyper successful. And people like the faculty that we have here and some of the doyens of urology in Kolkata here, they have gone on to have exceptional clinical experiences based on which they are proclaimed as experts in their respective areas. So these exceptional clinical experiences, which may or may not have been documented, there is a need to share them so that people can mull over them and eventually adopt them in their own clinical practice and ultimately make healthcare a much better place. The world is also moving towards something known as clinical reasoning. This is a review article by Professor Snyderman in Mayo Clinics. I know you'll not be able to read it from there, but I'll be happy to forward it to you should you want it. Basically what it says is that all these sources of information, guidelines, RCTs, meta-analysis, investigator-initiated studies, etc., they are the sources of data that we rely on to adopt a therapy or a drug in our practice. That's fine and that's relevant. But that is not enough for clinical practice, because that clinical practice and clinical research are radically different. In clinical practice, you have one patient sitting across the table who you have to deal with. In a clinical research, there is a group of patients that has to be dealt with, a homogeneous group of patients with all inclusion exclusion criteria. So what is also required for clinical practice is mechanistic reasoning and clinical experience. Once again, experience. Of course, there is no shortcut to gaining experience, it all comes with time, and this entire gamut is what is called clinical reasoning. So the more you accumulate the experience of others, try to adopt it, try to validate it, and eventually incorporate it in your practice, the better it will be. Why has this concept come up? Very simple, that while we are in an era of evidence-based medicines, because RCTs are the gold standard for validating anything. There is no doubt about that. They are and they will remain the gold standard to validate. But validation is not the end for clinical practice. If you have a great landmark trial, 3,000 patients followed up for 5 years, wonderful results, at the end of that, you say like 81% efficacy. Well, 81% efficacy means 19% failure also. Why did these 19% patients fail? Is it because of the therapy? The therapy is partial or the drug is partial that I will not act on those 19% patients? No, the drug is the same. The key lies in spotting the kind of patients who will best respond to the therapy. So this positioning is very important. Okay. Okay. He has just put me in my place. He says I must talk only through these mics because it's getting recorded. All right, so I can't move around. Now I'm on a leash. All right, the second reason why RCTs tend to be inappropriate, we have this new concept of non-inferiority that has come up. And anyone who wants to bring in a new drug, all they have to do is design a protocol where the primary endpoint is non-inferiority to the standard of care, and the regulator approves it. Now that lands up with a lot of confusion for the doctors lower down the line. If we have drug A, B, C, D, all equally good, which one should you choose? That answer is never given by anybody. And that is why, as I'll show you in a subsequent slide, guidelines are warming up to this concept. Third, the applicability of group results to an individual. Not possible. For the simple reason that in a RCT, you have lots of stringent inclusion and exclusion criteria to make the group homogeneous, which is the need of an RCT. But a patient in front of us will have several comorbidities. He may not conform to the inclusion exclusion criteria of the RCT. So then how do we apply the results is another $1 million question. Even guidelines, they have this caveat, they can be modified on the basis of individual patient circumstances and preferences. These days we have to take into account the characteristics of the patient, the economic strata of the patient, his own choice. If you are doing chemotherapy, he says, I don't want chemotherapy. You don't have any choice. You cannot give him chemotherapy. So patient inclusion into the process of therapy has now become very important, which is why compliance is no longer an appropriate word. It is adherence, where both doctor and patient are equal partners. Finally, now the practice guidelines are also recognizing this and they're fulfilling the lacunae. This is just an example of one such latest clinical trial released just in April. It is not from your specialty, I know, but it serves the purpose of pointing out the. This is about the practical guide on the use of non-vitamin K antagonist oral anticoagulants, the NOACs, so to say. And what they have done is they have taken 20 practical clinical scenarios that we encounter in hospital on a day-to-day basis. And whether clinical trials have shed light on it or not, they have opined, experts have got together, come to a consensus and opined about, okay, this is the best way to deal with this situation. And in their methodology, they're right, they admit, in some instances, the authors opted to make recommendations that do not fully align to all SMPCs with the goal to provide more uniform and simple practical advice. For example, if a patient has forgotten a dose or he has taken a double dose, how do we deal with it? No clinical trial is going to tell you that. There will never ever be a clinical trial to do that, to establish that. Secondly, they know that, okay, these are not based on RCTs, sometimes they are not based on the SMPCs, yet we have opined. So they are very open-minded about it, and they say the authors realize there will be gaps, unaddressed questions and areas of uncertainty and debate. Readers can address their suggestions. And then we come to the whole, the most important sentence at the end. This whole endeavor should be one for and by the medical community, with the ultimate goal of improving patient care and outcome. So this is what the world is gradually moving towards, and European guidelines in various specialties have often taken this into account, which is why I like them a lot. So we are hoping that in this meeting, with the discussions and suggestions and opinions and experiences of the experts and your own, you will have a good discussion so that it will be of benefit and enrich everyone. So with that, the introductory part is over. As you can see, there are 4 more slides left. And so for this introduction, I thank you for your patient impatience or impatient patience, whatever. And this is one of the most irrelevant and redundant duties that I've ever done, to introduce stalwarts like the Euro stars that we have here, but protocol dictates that I do that. So here you are, the Euro stars, Professor Christopher Chappell, Professor Maurizio Brozzi, Professor Arnold Stenzel, and Professor Seluk Sile. And this is another criminal offense that I've committed, shortened their long, illustrious CV into one short slide. Apologies for that. But so Professor Christopher Chappell, he's Secretary General EAU, trained in urodynamics and a doctorate in pharmacology. He's been running the clinical and basic research program in functional urology since 1992, contributed over 700 papers and chapters to books. He has been awarded the Lifetime Achievement Award by the Society for Urodynamics, Female Urology and Urogenital Reconstruction. He is Director Postgraduate Education for EAU for the last 8 years, and more importantly, he is also leading the EAU International Relations Office. 2006 to 16, a long innings as Editor-in-Chief, and obviously in the long track record that he has done innumerable number of surgeries, and most significantly they are centered around secondary and tertiary reconstruction and urogynecology. Then we have Professor Maurizio Brozzi, Chairman Urology, Director Prostate Cancer Unit at Modena, specialized in urology in 80 and oncology in 83. Fellow in oncology at University of Memphis from 86 to 89. He has authored a number of videos on new technologies and development in surgical approaches, and published more than 300 articles in peer-reviewed journals and chapters in several books. In a career spanning 25 years, he has performed more than 25,000 open, laparoscopic and robotic surgeries. Professor Arnold Stenzel, today I have changed the names. Chairman, Scientific Congress Office of EAU, HOD at Eberhard Karls University, Germany. 1980, he graduated from Karl Franz Zenz University. 1988, specialized in urology. 89, fellowship in urology, oncology from USA. Assistant professor in Austria and University of Bern, and went on to become an associate professor. He is member of EAU Committee for Study of Recommendations and Guidelines in Oncourology, a very important and responsible task. Member of the Advisory Board of Interdisciplinary Innovations in Surgery since 2006. He was awarded the honorable title Professor of Urology by Federal President of Austria in 1997. Also awarded the Werner Staller Memorial Prize and not just once, 4 times. And he holds 2 patents for implantable incontinence device and C-trap. And this, according to me, is the icing on the cake in anyone's CV and profile, because there are long CVs of a lot of people, but somebody who gets 2 patents, even if you get 1 patent, that's a wonderful achievement, and he has gone ahead and got 2 patents. So Professor Salak Saleh, Chairman, Department of Pediatric Urology, Director of Robotic Pediatric Urology, and I have not told him yet, but I was planning on nicknaming him. If after you see the presentation, you'll know that I'm not wrong, but I've kind of nicknamed him as the Turkish robot. And the pediatric population in Istanbul will agree with me, I think. Chairman, EAU Young Academic Urologist, graduated from Ankara University and specialized in urology at Istanbul and at Baylor College of Medicine. Pediatric Urology Fellowship Program at Texas Child Hospital. 2011, he became assistant professor at Istanbul Besmialem University. 2014, associate professor, published more than 60 articles, authored 8 chapters. And 2016, he got the prestigious Young Academician of the Year Award. And 17 and 18 followed up with the Academician of the Year Award. And 2018, he was felicitated with EAU Crystal Matula Award. So very decorated gentleman. So with that, I will not stand in the way. Sorry, just give me a minute. Forgot the paper. Sorry about that. So these were the Euro stars, and we have the Indian stars also, who will be chairing and moderating the various proceedings. I would like to hand over to the session to Dr. Arunav Chaudhary and Dr. Anup Kundu, please. They will chair the session and conduct the proceedings. Yes, sir, please. How it will go.
Good evening. Welcome to this program. Everybody, especially the juniors, are very much restless for the World Cup final, so we will not take time. I will request Professor Chris Chappell to start his deliberation. Professor Chappell.
Thank you, Dr. Chaudhary, Dr. Palau. Most grateful to you for the kind welcome.
Welcome, Chris. You have been here in Calcutta, I think, twice before.
Very nice to see you.
Well, would excuse us in order to watch.
I think you need to sit at the front, yes. Thank you very much. Great, well, thank you very much, and I'm most grateful for the kind introduction from Dr. Bhagava and his colleagues, and also from the USICON team and the Urological Society of India. We've already met people in Delhi, and it's great to be here in Kolkata. So, without more ado, I'd like to just first of all introduce you to the European Association of Urology, along with my colleagues, and also then give the first presentation to kick the meeting off. I bring you greetings from the board of our association, which represents many different nationalities across Europe. And the European Association of Urology, which I'm sure you're familiar with, is a charitable organisation which is committed to a number of key aspects to represent European urology, to help provide a standardised level of education and care across Europe, and to interact closely with our colleagues across the world to achieve the same aim, with the benevolent aim of improving the interaction between us, to learn from you, and also to bring you the information that we have so we can discuss it objectively. By doing that, we improve the standard of training, of practice, and also work closely with our patient groups to achieve this. The European Association of Urology was refounded by Frans de Bruijn in the early 90s, and hence is based in Arnhem in the Netherlands, but also interacts closely across the whole of Europe, as you can see from that slide. Now, the European Association in the last 2 decades has made enormous strides. A number of years ago, when I was first sort of going into urology, it was very clear that the guidelines that existed were largely those from North America. I'm sure you've probably seen, and you can access on Google anytime you want, the last edition of the EAU guidelines. As a member, you can get the latest update from this year. And these guidelines are updated every year. We spent €1.5 million last year on the guidelines, just on travel for the panels. The people who do the guidelines do it voluntarily. They're urologists like you, who are working for the association, and we have about 300 people working on the guidelines. These have been very well accepted. They're based on a PICO approach, as you heard from Dr. Bhagava. The importance of guidelines is to actually look at the population, the indications for anything, the comparators and the outcomes. So you pose research questions which you then answer from the literature. And as I say, these are updated every year. You can see the latest version from Copenhagen, and these are adopted by all European countries and all countries across the world apart from the United States that have their own, but ours are, as you know, the most up-to-date if they're updated every year. And of course, we're very proud of the fact that the Urological Society of India have adopted and accredited these guidelines. And as you can see, China and the rest of the Pacific Rim have also adopted them. Now, when I was training many years ago with Richard Turner Warwick and the others at the Institute of Urology in London, very much the premise was that you listen to the senior guys, and it was eminence-based urology. And of course that's still very important, but we've now moved towards more of an emphasis on eminence but also evidence, which is important because experience does count, as we heard, but equally the evidence is important. And Cochrane, who you've probably come across, Archie Cochrane, he was a gentleman, an epidemiologist in Aberdeen in the UK, set up the Cochrane collaboration, which was to follow this approach and really to sift out the highest quality relevant information to aid us with our practice. Now, guidelines aren't there as a stick to tell you what to do, but they tell you what the evidence is in the literature. It also tells you what we don't know. In other words, what are the research questions that need to be answered, which is equally important. Because at the end of the day, what we do know is far outweighed by what we don't know. And of course, common sense comes into it. I'm sure many of you may have seen this rather spoof article. Every year, the British Medical Journal has a series of articles which are slightly jokey. And this is one which reached the startling conclusion: you don't need a randomized control trial to tell you that jumping out of a plane without a parachute wasn't good for you. Because common sense clearly comes into all of our practice. But so does knowledge, and so does evidence, because otherwise we'll not treat patients as effectively as we might. And of course, to generate the evidence, you have to have good journals. Another thing we're very proud of at the EAU is the journal that we have, European Urology, which you can see the 2016 impact factor was 16.265, and this year it's gone up even further. So it's about 4 times the impact factor of many other journals in urology. And of course, we also have recognized that it's difficult to get articles into this, and so we have European Urology Focus, which has just got on PubMed. We'll have an impact factor very shortly, but much easier to publish in because there's less pressure to get into that. And of course, European Urology Oncology, which is following fast behind it. Now, obviously, within all of our practices, we have subspecialization, or you may wish to call it supra-specialization, which is more accurate. In other words, you train as a urologist and then you supra-specialize in specific areas if the opportunity arises. And in this context, it's great pleasure to have Professor Browsey here, who is chair of one of the most important sections of the EAU, the Onco or Uro-Oncology section. And we have 13 sections which encompass the whole field of urological practice. We also recognize the importance of oncology in our practice, and so we do have the EMIC meeting, which is a meeting directed at oncology, where the medical oncologists come along, but it's run by us as urologists. And that's very important, because the patients come to us as urologists, and it's very, very important that we keep abreast of the latest medical developments. And you'll be hearing more about that from Professor Browsey and Professor Stenzel later in the session today. And of course, within this, we also set up a task force, because in urology, we are missing out. A few years ago, we were the ones who used the hormone blockade, and now most of us aren't actually involved in medical oncology for many different reasons. The drugs are costly, chemotherapy is expensive, but the new drugs you'll hear about from my two colleagues actually have far less side effects, although they do have toxicity. But I think it's something that urologists should also be involved in, and that's what we strongly believe, hence our task force. Of course, with all this background, the most important thing also is education. As I mentioned, it's one of our main goals and mission statements in the association. In this context, the European School of Urology, which is our education arm of the association, looks at high-quality, unbiased information dealing with the latest developments. We have a website which all members have access to with Eurosource, which has 55,000 pieces of information, slide sets, videos, and goodness knows what else on there. And of course, within this, we have courses which are both general at our annual meeting and also at other times during the year with masterclasses and specific hands-on training. And one of those, for instance, a very popular one recently, is to train urologists to read MRI so that you can actually treat your patients more effectively, particularly for the prostate. And you can see just a selection of some of the different masterclasses that are put on with our various sections. Patient information is important because at the moment everybody looks at Mr. Google or Dr. Google, and a lot of the information there is complete rubbish, as I'm sure you would agree. So it's important as an association we have evidence-based information, and that's something which we are putting a lot of effort into with the various patient groups. So we really appreciate the strong support from the Urological Society of India in setting up this meeting, and this was a meeting which was set up with an unrestricted grant from Lupin, but which has been set up with the Urological Society of India, because we want to work closely in partnership with you as Indian urologists. And I'd like to also thank Lupin, because it's very unusual for a commercial organization to give us the opportunity to speak without any interaction or involvement in the actual content, which is just content from myself and my colleagues at the European Association. And here are my colleagues. I think they need little introduction. Just in order across there, following myself, you can see Professor Arne Stenzel, who's responsible for our Congress. And the EAU Congress usually has around 13,000 people attending. It's one of the bigger congresses in the world. It's the most up-to-date and first meeting of the year. And all members of the EAU have a reduced registration to that. Until this year, all residents went free, all resident members. There's a small charge this year, from next year onwards. Professor Browsey, of course, I've mentioned with the section, and Professor Selçuk Siley, who represents pediatric urology as well as many aspects of adult urology too. And so you'll see a very comprehensive overview. Myself, I am a urologist working in Sheffield in the UK. I trained in London, and I have done a doctorate in pharmacology in my career, which I thought was very helpful because it allowed me to work on the basic training urodynamics to understand the function and physiology of the urinary tract, and of course to implement that into surgical practice. I was very lucky to train with somebody called Richard Turner Warwick, who was one of the fathers of reconstructive urology, and John Blandy, who was the external for my thesis and supervised me. So I was very privileged at an early stage in my career. I moved up to Sheffield. Many of you will know Sheffield as being an industrial city. It's now post-industrial. You may have seen the Full Monty, which was during the times when the industry had collapsed. But it has something you may not realize, the best visited and first national park in the UK, the Peak District, and I hope that some of you will visit us. I certainly live there. Just there you can see, and that's my hospital. It takes me all of 7 minutes in the rush hour to get to work, so quality of life is excellent. And we have a very major unit with 16 consultants present, with one of the major units in the country. We provide a tertiary service, and we're one of the 3 centres that does reconstructive surgery on a regular basis. In the UK now, everything is centralising. This followed on from initially oncology being centralised 13 years ago to key centres, and this now applies to urethroplasty, fistula repair, mesh erosions, posterior urethral strictures, and so on and so forth, and for the rare diseases in other areas. I'm grateful to colleagues who actually were responsible under the leadership of Professor Stenzel at the Congress office for generating some of the slides that I'll use, which I've interspersed with some of my own. Now, the EAU, we also like to have some fun, but also to look objectively at the whole field of urology. We have a very active history office, and they all every year produce a publication, and here was the one from this year, which was Peeing in Art. And it's a fascinating overview of the way in which urology focuses in art. We've had various other titles over the years, and you can look them up on the internet and the EAU website. The guidelines I've already mentioned, and clearly the EAU guidelines have the principles that I've already mentioned in terms of evidence base. And this year you'll see for the first time, and it's the only set of guidelines in the world which actually tell you if the evidence is strong or weak. So no longer is it A, B, and C, where you'd never sure what B means. A is strong and C is weak, and there isn't an intermediary. So that's quite useful in terms of guidance. If something's weak, well, it means that you then have to use your judgment. But at least you know what the literature shows. If it's strong, then if you use your judgment and disagree with it, you've got to have a damn good reason for changing the view, because obviously the evidence is strong. Obviously, as a functional urologist now, where I do nothing but functional urology, I have done for the last decade, it's very important to have evidence. And in urology, the best evidence is provided by an objective assessment of the urinary tract. Don't forget that the bladder is an unreliable witness, because symptoms are not disease-specific. Patients report symptoms in different ways, and I can guarantee if you put 10 urologists in a room and ask them what various things mean, you'll get at least 5 or 6 different answers, because we all interpret things differently. And so you need to have an objective basis, which was the basis for what Turner Warwick and colleagues in 1969 introduced, where they introduced the field of urodynamics into modern clinical practice. At the end of the day, you need to think about the urinary tract as having filling and voiding phases. And filling occupies 98% of the bladder's time, even 99% you may say. So when you think about the urinary tract, people talk about the bladder becoming thickened because of voiding dysfunction, in other words, obstruction. How long does it actually take anybody to pee? Even if they've got prostate problems, it's less than 1% of their time, isn't it? Even if they're straining to void and taking a long time. What leads to thickening of the bladder is hypertrophy of the wall, which is due to overactivity of the muscle during the filling phase in both men and women. That's why neuropaths have the thickest bladders. So it's simple things like that that one should ruminate on and thinking about the urinary tract. Obviously, urodynamics is a way of introducing some evidence into the field, but I'm not talking with urodynamics about pressure flow studies. What I'm talking about is an assessment of the various components of filling and voiding. And in this context, the simplest thing that all of us should use in our clinical practice, because it costs nothing except a sheet of paper and a pen or pencil, is a frequency volume chart. And just getting the patient to jot down, if they've got a problem with the filling phase, how often they're going and what sort of volumes, even over just 2 or 3 days. How else can you determine if somebody's got nocturnal polyuria? You can't, unless you're actually measuring the volume at night and comparing it to 24-hour volumes. And remember that 30 to 40% of people who are a little bit overweight, who've got nocturia, which affects all of us to some extent over the age of 60, actually have nocturnal polyuria due to cardiac dysfunction, fluid retention, sleep apnea. And if you just put them on a drug, it's not going to work if you're trying to treat one of those conditions or if they've got diabetes. So at the end of the day, simple things like that are in the guidelines, have been for 15 years, and are ignored by most people. And in fact, if you look at the placebo effect in drug trials, that's because it's probably the first time those patients have ever used a bladder diary, because it's used in all of the trials. And bladder training and recognition by the patient that fluid intake documented will actually lead to symptomatic change is a very important factor. And indeed, if you look closely at some of the trials, in the placebo group, they reduce their fluid intake because they realize the importance, and in the active treatment, they increase their fluid intake as evidenced by output. So you can see that it's a whole structured approach, measuring the frequency volume, the bladder capacity, the residual. Voiding efficiency is another important concept. Voiding efficiency is the volume that the residual over the total bladder capacity, which is the volume voided plus the residual. And that's why you've probably noticed in drug trials 140 mils, 150 mils residual is accepted, and beyond that the drug they're not admitted to the trial because that's a voiding efficiency of 40%. And of course you've then got the pressure flow study we're all familiar with, which needs good quality practice to get the best results, and of course the basis of the Griffiths normogram, which is looking at the pressure flow hysteresis loop comparing pressure and flow. Of course, another basic premise within the field of functional urology is to use the tire Halt rings. Halt was from Denmark, from Copenhagen, and he introduced the concept that what you have to do is to think of symptoms, anatomy and dysfunction, and of course urodynamic function. And that's why the term BPH doesn't mean anything. That's why the horrible term LUTS was introduced by Paul Abrahams, because lower tract symptoms is what brings men to see you. What brings a man with BPH to see you? Is it usually that it takes him a bit longer to pee, or is it because he's got storage symptoms? Overactive bladder. He's waking up at night, he's caught short when he's out shopping with the wife, or if he's going to the cinema. Storage symptoms affect men and women, and it's indeed more troublesome than voiding symptoms. Remember, even if a man's got a very severe IPSS, the actual risk of retention is only 0.5% per year. So it's not a high risk. So it's a concept that one has to consider. Overactive bladder is not a disease. Overactive bladder is a non-specific symptom complex affecting men or women. And remember, if you look at urodynamics, in women with overactive bladder, only 40% of those that are dry have detruse overactivity, and only 60% of those that are wet have detruse overactivity. So overactive bladder and detruse overactivity are not the same thing. And the target for therapy is not the detrusor muscle. If you think it is, you're outdated, I'm afraid. For the last 15 years, it's becoming increasingly clear that all drugs will affect the detrusor muscle if they're anticholinergics or if they're Botox, but they're actually affecting the pivotal symptom of overactive bladder, which is urgency, which is a sensation, because the cholinergic receptors are not just on the muscle, but they're on the sensory nerves, interstitial cells, and on the suburothelial plexus. And so what anticholinergics do, and what Botox does within its therapeutic regimen, is to actually inhibit the sensation by blocking those cholinergic neurotransmissions. Because at the end of the day, there is acetylcholine released when you stretch the bladder. Whilst you're sitting there, you've got non-neuronal release of acetylcholine, ATP, nitric oxide. Indeed, nitric oxide, when it's scavenged by blood clot, causes the catheter spasm you see with clot retention. When you wash out the clot, the spasm goes away because that's a nitric oxide scavenger, and nitric oxide is the best relaxant of smooth muscle. So as you can see, whilst we all think of the detrusor muscle, which is important, of course, the target for therapy, and that goes for sacral neuromodulation, Botox, mirabegron, the beta-3 agonist, doesn't cause retention. It acts on the sensory mechanisms. Underactivity is the other side of the coin, because if your detrusor muscle isn't working, then you've got a problem. And of course, in many patients, that will merge with outlet obstruction, the so-called BPH enlargement leading to obstruction. And of course, a third of people, men and women, over the age of 65 to 70, have an underactive detrusor on urodynamics. And of course, then you've got symptoms of underactive bladder, which is a separate issue which we're looking at in research at the moment, because of course there you have both storage and voiding symptoms, because you have an underactive bladder, you have a large residual, and that will cause storage problems because you're not emptying the bladder. So you can see the whole concept is quite complex. Detrusor leak point pressures were introduced by Maguire, and this year at the EAU there's some discussion about these. It's now recognized that they're actually difficult to measure. There's no quantified standard for it, and in fact they're only recommended in the States because you get reimbursement by filling out the form. You've got to fill out the form for reimbursement to put a detrusor leak point pressure on. They're actually fairly useless because a third of patients don't leak on a detrusor leak point pressure that leak when you cough. Antimuscarinics are the gold standard, so called in the past, because were the most effective treatment, and there's clearly strong evidence from the EAU guidelines for their efficacy. But in the elderly, recently, there's been some concern about the anticholinergic load of many different drugs to which the anticholinergics add. And so, although they're very effective, just in the very elderly patient who's frail, think about whether you should be using an anticholinergic or possibly thinking nowadays about something like a beta-3 agonist. And indeed, the beta-3 agonist mirabegron, which is the first in class, has now been recognized by the EAU guidelines as having strong evidence, the same as an anticholinergic, and it doesn't seem to cause retention. There has been some concerns about the dosing in the United States, but in Europe, Japan, and much of the rest of the world, we use a standard dose of 50 milligrams. We don't dose titrate. And indeed, it doesn't seem to cause problems with hypertension unless you've got uncontrolled hypertension. It doesn't cause cardiac effects any more than an anticholinergic, and in the trials less, it's been suggested. And indeed, if you look at this, they can be used with beta blockers, although metoprolol is best avoided concurrent with mirabegron because of metabolism effects, not because it's a beta blocker. Stress incontinence, we don't have a decent drug for at present. In this context, duloxetine's been licensed in Europe, but has a lot of central effects like any SNRI. And so certainly it's not something that's commonly used. Remember, estrogen doesn't treat stress incontinence. It's quite good for urgency and urgency incontinence in the postmenopausal female, but it does not work on stress incontinence. Although there's some evidence, which was discussed this year at the EAU, that there are some androgenic compounds can be effective, and this is a subject of ongoing research at present in the pharmacotherapy field. There was also discussion this year about desmopressin with the release of a new formulation of this, and whilst there is good evidence it can treat nocturnal polyuria, beware of fluid retention, because if you're producing more urine than you should, in the elderly in particular, and women in particular as compared to men, there's a risk of dilutional hyponatremia. So certainly over the age of 60, you should always measure a serum sodium within 72 hours of starting the drug, and certainly a week or two later, and if you're concerned, monitor the patients. Botulinum toxin, onabotulinum, this was first described by Rick Schmidt, who's a urologist you've probably never heard of, but he's also the gentleman who was introduced sacral neuromodulation. And you may have seen sacral neuromodulation, Schmidt and Tanago. He's been forgotten, poor guy, but he actually took out the patent for Botox when he was in Denver, did Rick Schmidt, owned by the university now. And there's no doubt that botulinum toxin's effective. It does not, though, produce its effect by inhibiting the detrusor muscle, although there's no doubt if you use higher doses, you'll put somebody into retention. Something which came up at the EAU this year was a reanalysis of the long-term follow-up of the clinical trial data, which showed that retention is age-dependent. So in younger patients, there's almost a negligible effect in causing retention. And because this merges with what I told you earlier about underactive bladder, because you probably remember from many years ago from Pittsburgh the discussion of detrusor hyperactivity, impaired contractility, a urodynamic finding in the elderly patients, where you have overactivity on filling and underactivity on voiding. So you can have overactivity, which you might use to something like Botox for as a third-line treatment, but of course it could also cause more risks with retention if there's underactivity on voiding. So sacral neuromodulation is another third-line treatment like botulinum toxin, injection therapy, but the problem here, of course, is expense. So in our practice, certainly, and in most people in Europe, Botox is more commonly used because it's less expensive. And indeed, if you look at the data with sacral neuromodulation, there's clearly strong evidence for it, And a recent meta-analysis discussed at the EAU this year showed very clearly that it is efficacious, looking at randomized controlled trials. But amazingly, there's only several hundred patients included and only 300 in prospective studies, although there are thousands, hundreds of thousands of patients who've been treated with this. And this is the problem with the literature when it comes to clinical practice outside pharmacotherapy. If you look at real-life clinical practice, which has been reviewed by Philip van Kerrebroek and colleagues and Ruud Bosch in the Netherlands, they reported up to 50% failure with sacral neuromodulation at 5 years. And indeed, if you look at the Rosetta study, which compared Botox and sacral neuromodulation, a study from Duke in the States, the problem with this study was they used twice the recommended dose of Botox, namely 200 units, for idiopathic overactive bladder, and they showed using that with a higher dose that it was similar in many ways to sacral neuromodulation. So there you have a simple randomized study comparing the two, but of course you've always got to look in detail at the inclusion parameters, as I mentioned, and you can see that very clearly shown. So really for the future, we do need to look very critically at these treatments. Now you may say, why hasn't he mentioned posterior tibial nerve stimulation? Well, there was discussion at the EAU this year about implantable devices which you could implant on the posterior tibial nerve. But the trouble with using it without these new treatments coming along, which still have to be validated, is it's extremely expensive. And in our practice, you're talking about a patient coming up weekly and so on, and we don't have good long-term data beyond 3 months. So at this stage, it's not considered to be equivalent. It's more equivalent to pharmacotherapy, sacral neuromodulation, in terms of efficacy. It's also important to think of the anatomy and neuroanatomy of the lower urinary tract in this context. The innervation of the bladder, as I've mentioned to you, one has to think of the fact that the sensory side is important, and the sensory impulses go up to your brain, up the periaqueductal grey matter, and are transmitted to the frontal lobes and to the limbic system, the emotional centers. And that's why motion, for instance, people wanting to go to the toilet frequently before exams, has an effect. The actual contraction of the bladder is stimulated by the pontine micturition center, and there's inhibition of that, negative inhibition of that, by the limbic system, and when you release that, you then void. And that is the way in which drugs are working. They're producing a reduction in the afferent impulses going up, feeding into the sensation you need to void. And of course, urgency, a compelling desire to pass urine which is difficult to defer, is a pivotal symptom of overactive bladder. And the reason why my American colleagues talk about urge incontinence, remember urge in English is a normal sensation, is because the FDA does not believe that you can adequately measure urgency, and that's why all the pivotal trials use urge incontinence as a primary outcome measure, which of course is only a third of the patients we treat in real-life clinical practice. And of course the reason I had that slide up was because that showed that there was also crosstalk between the rectum and the bladder, and that can have some clinical importance. Mixed incontinence is another area, of course. If you've got both overactive bladder and stress incontinence, then here it's often difficult to know what to treat first. But most people now, although the evidence is weak, would suggest that you should treat with the overactive bladder first before considering surgery. And the evidence is that patients do less well if they've got mixed incontinence with surgery. Of course, if patients are elderly, because there's a higher prevalence of detrused overactivity as well, they also do less well. Now, of course, this leads on to discussion about incontinence, and in the female, it's very important to realize that incontinence occurs, as you know, related to childbirth, which can lead to intrinsic sphincter deficiency due to denervation, but of course it also impairs the pelvic floor, and with increasing age, this cholanginous degradation leads to weakness of the pelvic floor, and in any patient who comes to see you with stress incontinence, there'll be a combination of both of these factors. Bulking agents have come back into the frame a bit, because as you know, everybody's getting rather worked up about the use of mesh, but the trouble is, if you look at this real-life data, which was also discussed at the EAU this year from Scotland, looking at all of the treatments in Scotland over a 10-year period from the national database, you can see that injectables have a far higher cost, a higher morbidity, more hospitalization, and a greater failure rate. So I wouldn't recommend them as first or second line treatment. They're quite expensive too. Of course, the gold standard was the birch copper suspension, which I was brought up doing. People have looked at trying to hitch things to the side wall of the pelvis, but again, the tissues are weak and it tends to fail. So I always tended to, and still do when I do this, on occasional cases I do it, hitch it up to the pubic bone or to the ligament. Because at the end of the day, the Richardson paravaginal repair also doesn't work because the tissues are weak. But the problem with copper suspension, which some people are going back to because of the concern about mesh, which is very topical at the moment, leads to a 20% central prolapse rate. And of course, artificial sphincters are not a really good option in the female because of cost. And of course, if you're doing it for redo reasons, there's a high failure rate. I think many people have forgotten the good old autologous sling, which was first described in 1908. And the modification of this is a recognition you do not need to leave the fascia attached to the rectus, which causes more pain, but you can actually go for minimally invasive approaches such as a sling on a string. And whilst many people would be familiar with an autologous sling used for type 3 incontinence type, as you can see, you don't want to, in most patients with stress incontinence type, you want to have a mobility of around 40 to 45 degrees with a cystoscope at the end of the procedure. And that, of course, is the standard one for type 3 incontinence. I'm not talking about that. I'm talking about the sling on a string that I was trained in doing 30 years ago when I was trained. And this is a procedure which basically we now have 10-year follow-up on. This is a randomized study we did in the UK between TVT and the sling on a string. And you can see the data, if anything, slightly better with the autologous sling. And there isn't a higher retention rate because I'm talking about an autologous sling put in mid-urethral and loose, as I'll now show you. We're all familiar with the TVT and, of course, the TOT, and, of course, it's been a treatment which was introduced based on the Ward-Hilton study, which was based on 200 patients versus 200 with copper suspension from the UK. And that study showed a 4% erosion rate, and that is often forgotten. And of course, that based on that, this happened in the literature. Something that none of us could be very proud of, that millions, literally, of patients have been treated based on experience with 200 patients, putting polypropylene into the vagina because it had been used as animal data and no follow-up. And there's no doubt it is the standard of care. In all of the contemporary reviews, including ones that I've been involved in writing for the European Commission and for the European societies, the use of a TVT or TOT procedure is effective as long as you counsel patients effectively. But the problem is that the material stays behind and it's got the wrong biomechanical characteristics to be put in the vagina. And that's now realized, but there is nothing else at present. Xenografts, whether from animals or allografts from other humans, cadaveric or placental tissue, don't work. They generate a T-cell response, and that's been clearly shown. Autologous tissue, you can't get enough for prolapse, but certainly, as I've shown you, you can for sling surgery. And if you look at the data, this is just the data from the Ward-Hilton study, 4% erosion rate. And if you look at the Thomas study from the United States, up to 4% major complication rate. So you have to warn patients if you're doing this, this may occur. But there is a feeding frenzy at the moment from the lawyers in North America, and there's also problems in my country with patient groups, with people who've been injured by this procedure, who may not have been adequately counselled. And so our government in the UK has just banned the use of synthetic mesh for the time being, for anything, including sling surgery, where their evidence is that it's actually quite a good treatment when carried out by an appropriately trained person having counselled the patient. And the trouble is, when you're putting any material into the vagina, it's quite different to the abdominal wall because, of course, the vagina has a sexual function and is exposed to some trauma during intercourse and also is mobile. And so you've got the wrong material, it can actually cause long-term problems. So you've got to think about the nature of the material. And what we've been involved in my centre, and we reported our data this year, is been looking at whether one can produce a different material, which is synthetic, and polyurethane is something which we're introducing into clinical practice in due course. You need to think, if you're looking at autografts, what cells should be involved, what scaffold, and what inflammatory response results in terms of treatment. And so, of course, it's tissue remodeling that you're trying to achieve. You're trying to produce a fibrous scar to hold up and support the base of the bladder, so that when you cough or laugh or strain as a female patient, or as a male patient post-prostatectomy, you have some support. And of course, this is just encapsulates 10 years' work. You can see, you can identify the most appropriate matrices, and you can look at the cell viability, the attachment of cells, collagenous production, elasticity of the structure, and the tensile strength. And so that's the sort of research which we do discuss at the EAU, which actually will come along in 5 to 10 years into clinical practice, hopefully. At the end of the day, if you're looking at mid-urethral slings, bearing in mind what I've said about the legal aspects, the governmental aspects, the mid-urethral sling using synthetic mesh using polypropylene is recognized as having level 1 evidence and strong support for its use as long as you know what you're doing, you're used to selecting the right patients, and you counsel the patients appropriately. And the autologous sling also is effective and certainly is cheaper, although there is about 20 minutes more surgery involved doing it, and there is a slightly higher early retention rate for around 3 to 5 days at a maximum, in my experience, if it's put in loose and mid-urethral. So I usually use a standard approach. Instead of a midline incision, I make a transverse incision, go underneath the pubic bone, as you all do when you're doing a sling surgery, having injected with an adrenaline agent, mobilize a small amount of autologous fascia from the abdominal wall, and then cut down onto the pubic bone, use a needle which is specially produced for that, which you can walk them. The storage, voiding, and post-micturition symptoms, much better than LUTS as a term. Epidemiology is important. It's been recognized, and it was presented at the EAU this year, that indeed allopurinol may reduce the prevalence of prostate-related problems due to benign prostatic hyperplasia. And the same applies to statins, where there's now evidence there's a 30% risk reduction of so-called BPH with statins. If you look at the epidemiological data, very clearly you can see also that there is an increased problem with diabetes. And this is probably because it leads to underactive bladder, impaired detrusor contractility, and will therefore be seen as BPH. But again, you're talking about voiding dysfunction, as well as storage dysfunction and bladder underactivity. New treatments are being looked at all the time. As you know, Botox does not work for the BPH. There have been 2 phase 3 studies, both of which were negative, not different to placebo. But certainly there's been look at changes in prostate volume using agents such as peptide vaccines. And in this context, it's also recognized in the algorithm that a beta-3 agonist can be very effectively used for treatment. If you're coming on to surgery for benign prostatic hyperplasia, then as urologists we have a toolbox. The standard of care still is the TURP, using modern generators, whether bipolar or unipolar devices. But of course, there's always new treatments coming along. Green light laser is largely considered by many people to be less effective than it might be, because there's slough that comes out for 6 weeks. It's, of course, very safe and effective if you're on anticoagulants, but as you know, it's gone through 3 power escalations to get to the latest device, and it is more costly. There's no doubt that homium or loop enucleation of the prostate is very effective, but there's a steep learning curve. And this is, of course, if you look at the EAU guidelines, the algorithm clearly demonstrated. New treatments have come along. There's the Urolift, which is highly expensive. It's a plastic strap. In my country, they cost upwards of £700 per strap. And the evidence is that it's likely that these, in my view, I've got no evidence for this, they will cut into the prostate and become less effective. But they preserve ejaculatory function. But the efficacy that you see is about the same as an alpha blocker, to be honest, slightly better, not the same as a TURP. And the trial, which is often reported from Europe, actually, if you look into the selection criteria, excludes around 95% of the patients that we considered for the trial when we were doing it. So does it reflect real-life clinical practice? And there's no doubt that you do get efficacy if you look at the follow-on from the randomized controlled trial. And of course, the guidelines have to follow the evidence. But it's always useful to look behind this and realize It's only for smaller prostates, for somebody who wants to preserve ejaculation. And again, it may be a very select group. Aquablation is all the rage in some circles now, using water to enucleate the prostate, which you can do in 4 minutes once you've done an ultrasound and drawn your lines, but it's equally quite feasible to consider that some people who may not be so expert at it may draw the lines around the rectum or the sphincter and ablate that too. And I have never used this, but I'm told by the colleagues who have used it that it then takes 35 minutes to stop the bleeding. So at the end of the day, there's always pros and cons, but there's no doubt you can effectively ablate the prostate using this in a similar fashion to enucleation of the prostate. And again, it'll find its place in due course. Again, you've seen that various springs and coils have come back in. There's always enthusiasts for this, but time will tell how effective they are. There's also the Resume device, which does look interesting. Again, it's another way of ablating prostate, and it looks interesting that it may be effective, but again, you can see limited data, real-life study of 129 patients from an enthusiast in the area, and time will tell as to how effective it is. There's been a lot of enthusiasm also for ablation of the prostate using embolization, which again will become a radiological technique, but it's not without its dangers. You need an expert radiologist, because you're not dealing with end arteries, and you can easily ablate the base of the penis or the base of the bladder, and that has all been reported. And the evidence is that it improves the flow rate by around 4 mils per second, whereas a TURP in the ROPE study from the UK doubled the flow rate by 10 to 12 mils per second. So there was also a reoperation rate of 20% in recent data, which was reported by 1 year. So at the end of the day, there are new treatments always coming along, and I think it's very important for us as urologists to always look critically at the new treatments to see what we should be using to reach our own conclusions about what's effective. And realize that BPH is not what we're talking about. We're talking about symptoms: storage, voiding, and post-micturition. And we do have enlargement of the prostate, but you can have a very enlarged prostate with no obstruction if it's peripheral, and very little enlargement if you've got bladder neck obstruction, and you often see that with chronic retention, small prostates, because in fact it's underactivity the problem, not obstruction. So a simplistic view about BPH is fine if you want to be simplistic, rather like OAB, but as urologists it's important for us to look behind the words and realize what we're talking about. Post-prostatectomy incontinence, not much new to say except to say that our colleagues who do oncology, sitting there as you can see, are actually doing a very, very good job, because despite the meteoric increase in number of radical prostatectomies, there's actually not been a huge increase in expert hands in post-prostatectomy incontinence. The question is whether the robot is the be-all and end-all, and there's no doubt that in effective hands, the robot is very effective and provides a minimally invasive approach with somebody getting home faster, but at a cost. And if the person isn't expert, as has been seen in some countries, there's a learning curve and you can have worse morbidity. So looking to the future, we also need to think about the next generation coming behind. I'm not going to deal with this in any great detail, but just to mention as a prelude to Professor Zille's presentation that there was a working party we set up at the EAU, and I was very keen to establish this, which was looking at the importance of medicine for patients that were going to actually evolve from the pediatric sector to adult life. Really, transition medicine, which was a concept first introduced by Chris Woodhouse from the Institute of Urology in the UK. And based on that, Dan Wood led this group, the principle of which was to look at the principles of lifelong care, transition from pediatric to adult care, and to look at ways in which we could improve that. Also, as a prelude from an adult urology perspective to the pediatric presentation, Professor Sille, I'm going to mention just hypospadias. And really there was also data discussed at the EAU which about the length of follow-up. And there's no doubt if you look at that data, you can't really see it, but many series have a 30% complication rate. Now in expert hands you can get fantastic results, and you see that from the big centres. But if you're an occasional surgeon doing hypospadic surgery, there will be significant complications. And if you look at the outcomes, you can see that very clearly, and this has amazing consequences for patients if the thing that's in their trousers is something they're rather ashamed of. It may actually cause voiding dysfunction, there's cosmetic problems, and huge psychosexual problems. And this is what I've seen in my practice as a urologist, being referred at a tertiary centre to deal with. None of these issues are easy to deal with, and we presented some of the data from our unit which was looking at it. And I would just emphasise to you that in fact, although you can proudly say how good you are, you have to acknowledge that there are complications which you have to warn the patient about before carrying out the surgery. But if you, at the end of the day, if you persist, this is just a smallish series of 72 patients treated over about an 8-year period. You can see with 4-year follow-up on the patients using endoscopy, so a very harsh way of looking at the outcomes, you can see that the majority of them did rather well because they may have needed up to 4 or 5 operations to get things right. So adult hypospadias you can retrieve. The pediatric urologists are excellent and the results are good in specialized centers, but there can be complications if you do it infrequently. The last slide I'm going to show is just an initiative which is an important one, which I think has implications within Europe and which I'm sure many other countries will follow. And that is the principle of super-specialization. If you're dealing with rare conditions, congenital conditions, or rare conditions like penile cancer, retroperitoneal tumours, testicular cancer, as we'll hear from my colleagues in oncology, from Professor Browsey, for instance, with testicular cancer. If you're dealing with the consequences of mesh implantation with erosion of the female urethra, female diverticular, or whatever, is to actually have pooling of knowledge, to have databases, to have good guidelines. And the EAU is very proud that we've led an initiative in this area, which has led to a pan-European group, which is being funded by the European Commission, which provides an online multidisciplinary team discussion. And this is something which my oncologists already do. They may, in Germany, for instance, use chemotherapy and so on, but in countries where we don't, we have MDTs, where we sit down with the medical oncologists and discuss it. And we still have the leadership role in that area, but we need to work on that as urologists, so we also are involved in the research with new treatments. And this is the principle of a multidisciplinary team, and this whole process is funded by the European Commission, and we can sit down and talk across 30 countries, 29 countries at the moment, actually doing online MDTs using a secure website, putting up X-rays, MRIs, discussing the data, and then reaching a consensus to provide people with advice about how to treat rare conditions like the ones we've mentioned. So without more ado, I'd like to thank you for the attention. I hope I've given you some insight into some of the functional urology hot areas that are ongoing at present, and I hope that you'll join us at the EAU meeting, which is going to be held in Barcelona next year, where we will continue the debate. Thank you very much. I think I took 45 minutes, including the introductory slides.
Thank you, sir. I am now, if you have any question, please have a talk with Professor Chappell at the end of the session. Now I am requesting Dr. Kullan Sarkar and Amit Ghosh to moderate and chair the next session.
I'm very happy to discuss things later during the dinner and around the football, when the football's finished. Thank you very much.
We are well into the evening with this very interesting session with Professor Chris Chappell. I think everybody was boiling to ask Chris a number of questions, but we are probably having to preclude that for lack of time and lack of this world event tonight. Even then, is there a dire emergency question that you really want to address face to face with Chris? We'll answer one or two and move on to the rest, okay? Let's be very, very brief. First one, behind the record. Yeah. Be very brief. And Chris, may I ask you to come over for 5 minutes, yeah? We'll restrict our time to 5 minutes.
I'll be brief too.
First of all, let us be precise with the question. Let us also be focused that whereas Chris has given us a very overall view of guidelines, etc., which are based on the European and the Western population, our Indian urology is different. So let us ask questions which are relevant and are challenging. Let's get the microphones ready. We can't afford to waste time. I mean, this is luxury, yeah?
Good evening, sir. Hello, sir.
Yes, carry on.
You have been associated with urodynamics for probably last 30 years. But have you come up with a grade 1 or strong recommendation for doing urodynamics in specific cases?
Thank you.
Is there any specific recommendations in EAU guidelines 2018 for urodynamics?
Thank you. Very good question. Excellent question. The honest answer is no, because nobody has done randomized controlled trials until recently. Next year you will have the master study, the study which is being carried out in the UK looking at the role of urodynamics before TURP, so that will have level 1 evidence. And in 2 years' time there will be evidence about the role of urodynamics in women with incontinence if you're going on to consider surgery or treatment for overactive bladder. So those are 2 studies which will be published within the next 3 years.
Okay, thank you very much.
So
Divakar, yes. Second question, and we'll have a third question.
Professor Chappell, just one question regarding the mesh erosions and the efficacy of the TOT TVTs.
Yep.
We were used to train on pubo-vaginal slings in UK 20 years back.
Yep.
Are you suggesting that that procedure is coming back?
Yes, it's coming back certainly. Tim Stevenson taught me 30 years ago how to do the minimally invasive sling procedure I've shown you. All my career I've offered it to patients, and roughly a third of my patients have selected that, because as a reconstructive urologist I've always spent my life taking whether it was STEMI cuffs or taking Marlex meshes or whatever else out, and it's no surprise to me that if you put a synthetic around the urethra, particularly somebody who's not used to doing it, they skin the vagina and get a vaginal erosion, or worse, they actually put it through the urethra or put it through urethral diverticulum, which I've also got quite some experience of dealing with. So the bottom line is I've always offered it. If you counsel people appropriately, a number of patients have always gone for an autologous sling, and I've had very good results over my career with it. Although, like all surgery, there can be complications.
Right, thank you. I think
Thank you.
there's a flip side to it. I think the TOT, TVT are being mostly used by gynecologists. With the pubo-vaginal sling back, I think the ball game would shift more towards the urologist.
I think you've made a very good point, sir, which is that urologists have a great opportunity here to actually re-engage in the area of female incontinence.
Chris, I have a question for you. I just
Certainly.
wanted to put the Indian urology into context, and that is where I use your presence to actually maximize the utility of guidelines.
Yes.
We face, in the Indian culture,
Yeah.
we have to perform a one-stop shop.
Yeah,
We haven't got the luxury of tremendous follow-ups that you have the luxury of.
I
in
understand.
England. So therefore, if you have a walk-in patient with a catheter at a 72-year-old gentleman where you're not suspecting prostate cancer with a PSA of 13, how would you manage that?
So you've got a patient who's got a catheter in.
Is got a catheter in, good history of LUTS,
How old?
72 with a PSA of 13,
Fit?
smooth fit, very fit. What would you do?
It's always a difficult one, that, because if somebody's got a catheter in, that can raise the PSA, clearly.
Correct.
If they've got a large prostate, which is more likely they've gone into retention.
He's got a 60-gram prostate, yes.
Well, it's not that bad, so it will raise at PSA, but not to that level, to 13. I mean, what we would do would be an MRI nowadays, because that's the evidence base. That would be my view. But equally, it wouldn't preclude you from doing a surgical procedure to get them out of retention, then reevaluate.
You're very right. This was the real question as to how do you screen for prostate cancer in an Indian patient, and where do you stand legally for that? In many cases, I wouldn't say all, in large percentage of cases, urologists in India would straight away, with a good history of LUTs, would be forced to do a definitive surgery, which is, I think, probably justified. But here comes the fallacies of guidelines.
But you also want to put your finger in it rather than putting your foot in it and see if it feels malignant.
Absolutely.
Of course.
And yes, yes, Dr. Pradhan. I would restrict the question to 2 because Dr. Sharkar has got a question, Dr. Pradhan has got a question. We are embarrassed to close questions, but we have to. Yes, Dr. Pradhan.
I got my urology training in UK for 6 years, then returned back to India in 1983. I'm doing practicing in the urology here for the last 55 years or 32 years. And my bread and butter is pure prostate,
Sure.
which I have learned here. And still I am doing, I have done more than 20,000.
What's your question?
Pure prostate. In your now, last 2-3 decades, we are saying that there are different anarchies are used, different procedures are come up.
Okay, to answer your...
In your opinion,
yes.
what is the fate of pure prostate?
TUR prostate is still... Thank you. TUR prostate is a standard of care in the UK still. I chaired the NICE guideline on male LUTs, and it was a recommendation as primary treatment. The other alternative, if you have the access to it, which you can do with a loop, not with a fancy laser, is TUR enucleation of the prostate, which is more akin to a retropubic prostatectomy. The rest of the treatments are considered to still be rather expensive, and most of them not very well validated. You're quite correct.
Thank you. Last question, please.
I just said that, using a loop. I know. Absolutely. I agree with you, sir.
Okay.
I did say that, sir. I agree. I agree with you. And you guys are very expert at doing it.
Mr. Chappell, in an European court of law facing a medical legal case, would your guidelines be quoted by either the defense or the...
The guidelines that we have are based on the best evidence there is. But the advantage of the guidelines now is that they say strong or weak. If the evidence is weak, then it would not be considered as gospel. But if the evidence is strong, then it would be supportive of urologists if they followed them.
Thank you.
We've now closed this first session. Can I now welcome Professor Maurice Brauzy for his lecture on prostate cancer.
Thank you, Mr. Chairman. Dear colleagues, it's a real pleasure to be here with you discussing about prostate cancer, testis cancer, and penile cancer. Okay. Why you close it up? Okay. Excuse me, but this, I cannot open my slide. Why you close it? Okay. See. Excuse me a second. Okay, here it is. Thanks. My duty today is to go and talk about prostate cancer. But first of all, I would like to introduce myself. I'm Maurizio Brauzy. I'm chairman of the European section of Uro-Oncology, and I'm coming from Modena, Italy. Modena, Italy is just in the northern part of Italy, as you can see from the star, and very simply is the place where the Ferrari factory car is. So you understand perfectly where I'm located. As I said before, I will discuss with you about prostate cancer, diagnosis and screening, localized prostate cancer treatment, oligometastatic prostate cancer, testis cancer, and penile cancer. What emerged from the EAU this year in Copenhagen? I have no potential conflict of interest to report, and we'll start with prostate cancer early detection and screening. Office for a second opinion. His PSA is 3.5. DRE is negative. TRUS showed 25 milliliter of prostate gland, homogeneous morphology, no suspicious areas. IPSS 6, IIEF 30, no comorbidity. However, he has family history of prostate cancer. He had father and one brother. So the PSA is there. Recommendation by local urologist, just do a TRUS-guided 2-core biopsies. However, the patient was smart, he's very smart, and he want to know what is the best possible diagnostic approach with the lowest complication rate, and is specifically risk developing. And we know that factors involved in the risk of developing prostate cancer are age, lifestyles and diet, hormones, race, geography, and family history, genetics. We know that cancer is a disease of the genome, and the cell with accumulated DNA damage and mutation can be potential cancer. We know also that we have somatic mutation and germline mutation. Just to be very simple, the somatic mutation are alteration of DNA occurring after conception, and they occur in any cell of the body except sperm and eggs, and therefore are not transferred to our children. While germline mutation are alteration of DNA in the reproductive cell, sperm and eggs again, and are passed from parents. So they are transferred. And they are also called hereditary mutation. This is important. So the genetic predisposition to prostate cancer, there are some conditions. First, family history is important. Second, hereditary syndromes are important, the Lynch syndrome. Metastatic disease and the early onset of prostate cancer, when a patient has prostate cancer less than 55 years old. I think this slide is a very important slide because it is a synthesis of a consensus on role of genetic testing in hereditary prostate cancer, which came out in 2017 in the States. They looked and they asked themselves, which man should undergo genetic counseling and genetic testing for prostate cancer? And they found out that hereditary cancer syndrome, the age at the diagnosis, as I said before, family history, metastatic disease are important. And then, which genes should are involved in this? And you can see here, this, even if it's very difficult to see, but the BRCA1, BRCA2, there are genes for breast cancer, OXB13 is a gene producing prostate cancer, and others are studied very well. So the distribution of presumed pathogenic germline mutation are here. BRCA2, BRCA1 are important. Also check CAPE2 and others. What happens during the EAU? During the EAU this year, it's been discussed, this Philadelphia Consensus Conference for Inherited Prostate Cancer, and the question was, are these genetic testing ready for prime time? And everybody was agreed in saying that the personal familial history of cancer like prostate, breast, ovarian, cervix, and Lynch syndrome is important, and all men with metastatic prostate cancer also. And BRCA mutation of tumor profiling for castrate-resistant prostate cancer. And why this is important? Because if we know of an individual genetic profile, we can identify men at risk for prostate cancer development. And in this case, we can act with targeted screening this patient. It does mean doing a frequent PSA or an MRI, even if this guy has PSA very low. And this is an important message. Or when we have prostate cancer, we can target a personalized treatment in these patients. So this is the sense of testing for genetics. In summary, the better knowledge of the genetic changes, both germinal and somatic, of prostate cancer will change our clinical practice. Germinal genetic profile can predict the risk to develop prostate cancer, usually tumor that develop earlier and with worse prognosis than in general population. Selected high-risk population is the population with patients with family history, hereditary syndromes, and early development, metastatic disease. But practically, with what we do, do you have any chance of having a genetic test done here in your place? No. BRCA mutation is available, but you don't use, of course. No. Okay. Okay. So what should we do if we are not, if the test is not available? Practically in our office, we can interrogate our patients. Patient history is important. So we have to ask not only if in family he has prostate cancer, but we have to ask also if in the family is breast cancer, cervix cancer, ovarian cancer, and Lynch syndrome, which is a colon syndrome. So this is the first message. In this way, we can individualize the risk of this patient of having cancer, and we can prevent also possibly an high-risk cancer. How about diagnosis? In diagnosis, we started with DRE, PSA, coming to multiparametric MRI, and of course, prostate biopsies. And the first question we pose ourselves is, what is the best possible way for detecting prostate cancer we have, doing biopsies? Is it standard biopsy we do, or since we have MRI, should we target our prostate with MRI? This is the precision study, which was presented at the EAU this year, and this study was conceived in order to give this answer. The study included patients with clinical suspicious prostate cancer, patients who had raised PSA or abnormal DRE, and they were randomized 1-to-1, there were 500 patients, to multiparametric MRI or to 12-core TRUS biopsy. And the primary objective and outcome was the proportion of men with clinically significant prostate cancer which does mean Gleason score 3+4 at least or more. And the secondary endpoint was the proportion of men with clinical insignificant cancer, Gleason score 3+3, and the proportion of men who can avoid biopsies in MRI arm, and of course, complications. These are the results. The study was very clear. If you use targeted biopsies under MRI, you can detect more significant cancer than with standard biopsies. And the difference was statistically significant. In one arm, you have 38% detection versus 26% detection. So we have the answer. Now we have MRI, we have to do biopsy with MRI. So MRI target biopsy strategy resulted in 28% fewer men needing biopsy. So we spare also this procedure. Fewer biopsy core required, 12% more men with clinically significant cancer detected, 13% fewer men with clinically insignificant cancer, and more favorable 3-day patient-reported complication profile. However, we have to keep in mind that when we do this procedure, we have 3 drawbacks. We have to pay attention. First, we need a very good radiologist to interpret MRI. Second weak point is a good urologist doing a very experienced urologist doing well the prostatic biopsies. Third, we need a pathologist who can interpret and find the Gleason 4. Gleason 4 interpretation is sometimes controversial. So we have 3 weak points. If you are in a tertiary center, like in this place, in this study, everything fine. However, the challenge is to bring these new things to non-expert centers. So we have to keep in mind these 3 things. Then also during the EAU this year, prostate cancer screening was tackled. We know it's a controversial. I brought to you this slides. This is the controversy in the state. This U.S. task force said in media that the patient over 70 should not be screened. However, AUA, as the American Urological Association, was not with the same line. And in fact, they said we have to do an informed discussion in those patients with the age of 55 to 70. Then NCCN is for screening in patients with age 40 with PSA and DRE, and repeat every 5 years if PSA is less than 1. EAU, UK, and New Zealand is against. However, EAU said we have to discuss case by case. And the Japanese Urological Association is for, with a baseline PSA at age 4, annually after 50, no cutoff. What happens? What are the studies done and that appear in the EAU during the EAU? It's a nice paper by OSIS from the most important randomized screening study in Europe from Rotterdam. Is a pilot study. This is an abstract, of course, at 19 years in non-contaminated population in which 60% of men died. They found out that the screening reduces metastatic disease and mortality. You can see the 2 lines, the two curves. The green one is the arm, the screening arm, and the red one is the control arm. Moreover, Hugoson, Göteborg. Hugoson is the director of this randomized study. Men in PSA range 1.83 nanogram milliliter at targeted biopsies only if MRI was suspicious, and the detection rate of cancer if PSA is more than 3 ranged from 14% to 23%. Then also active surveillance in prostate cancer was discussed at length. Just a slide to show you what who are candidates for active surveillance in studies: very low risk patient, intermediate, questionable. Some studies included, some studies no. However, they use DRE, PSA, PSD, trust biopsy, and 1-3 course of Gleason score 3+3, and some studies included also Gleason score 3+4. These are the criteria of inclusion, PRIAS for instance. But how about the role of multiparametric MRI in active surveillance, in selecting patients for active surveillance in 2018? So we had, during our meeting, 8 studies, 931 patients assessing MRI before confirmatory biopsies, and the reclassification rate was 32%. If we use targeted and systemic biopsies, it is 13%. If you use systemic biopsies alone, 11%. If you use targeted biopsies alone, 8%. And we have 2 reported studies saying that baseline MRI as a selection criteria for active surveillance reduces the misclassification at entry and decreases early reclassification rate. One is from Milan, from Suardi, 10% at 1 year and 14% at 2 years from Olivier Lille. Another very important question is, in our trial, when we do active surveillance, we control our patient with biopsies. At 1 year PRIAS, for instance, you must do biopsies in order to be sure that the patient does not progress. And so then the question is, can MRI improve the detection of clinically significant prostate cancer during follow-up? Which is very important, because instead of doing a biopsy, we can do an MRI, and the patient is much better. Even because some patients refuse to have biopsy after 1 or 2 years. So this is a 3 study with multiparametric MRI at start of active surveillance before each follow-up biopsies. And so they look if MRI progressed. And if we have progression at MRI, 35–70% of our patient, our tumor, are upgraded at subsequent biopsies. If we found a stable MRI, only 32% of upgrading at subsequent biopsies will be found. In summary, progression of MRI does mean histological progression. Stable MRI does not rule out histological progression. And there is a need to define robust criteria for progression. There is a trend, but we are not sure yet. What happens if we combine clinical data with MRI? We'll be able to improve this data. This is a nice study published by Nassiri in the Journal of Urology last year. They look at 206 men on active surveillance after fusion biopsies, the best. And independent predictors of progression at 3 years are resulted: grade group 2 cancer at the start of active surveillance, PSA density of more than 15, MRI score of 5. Omitting biopsies when multiparametric MRI is negative. If we have a negative MRI, we don't do any biopsies. We avoid 36% of biopsies, but we had 7% of grade group more than 3 tumor missed. What happens if we use also PSA density? We avoid 50% of biopsies. However, we cannot avoid the 7% of patients with grade group 3 tumors. So in summary, multiparametric MRI is recommended before confirmatory biopsies. Confirmatory biopsies must include systemic and targeted biopsies. The role of multiparametric MRI during active surveillance follow-up is still unclear. Robust criteria for progression at MRI are still to be defined, and for now, a negative MRI does not predict the absence of progression. Combining clinical and MRI data could help in defining patients who could safely avoid follow-up biopsies. So the take-home message from the first part of my talk is genetic testing need to be ready soon for prime. Genetic counseling and testing options should be clarified. MRI as a triage test before first biopsies will represent new practice. I ask you a question. If you have a patient coming to you with PSA, 60 years old, PSA of 4, and you feel the prostate is negative, do you ask for MRI right away or not? No? How many yes? Nobody. No. Everybody. Okay. So, MRI will represent new practice, allows not to biopsies 1/4 of men with non-suspicious MRI. To be used, it need good quality MRI, and you can also add PSA density and familial history, however, are controversial. Baseline MRI results be part of active surveillance selection criteria and reduce the reclassification during surveillance. So another issue has been discussed during the meeting was the low-risk prostate cancer and active surveillance. For instance, these studies looked at 4,822 patients with low-risk prostate cancer operated with radical prostatectomy in 2006-2016 in 2 institutions, and they looked at the rate of low risk in 2006 and 2016, positive biopsy course, PT3B44, and rate of upgrading, and the 5-year biochemical recurrence rate. And here are the data. You can see in 2006, the rate of low risk was 67%. In 2016, 17%, which is good because, you know, we operated many low-risk patients. And the PT3B4 was 1.2% 10 years ago. Now is triple. The rate of upgrading, this is important, 41% in 2006, 80% in 2016. Less low-risk patient, but increasingly high rate of initial misclassification. Not all low-risk patients are low-risk. Another interesting paper I found and I found really interesting during that meeting was active surveillance, the protocol, Priya's protocol. Everybody is looking for the results. So first 15 patients from 2006-2008 with a follow-up 10.9 years, very long follow-up. What happens? 65% of the patient dropped out of active surveillance protocols in a median time of 2.3 years. Second, 90% were tumor-free biopsies were no upgrade. 35% with Gleason 6 in radical prostatectomy were found. And therefore, even with active surveillance, there is still a high rate of overdiagnosis and overtreatment. So not all active surveillance patients switching to treatment are high risk, but this depends very much from the inclusion criteria, I think. This was another good piece of information we had. This is a prospective studies with the new active surveillance protocol, including MRI and follow-up, which is unusual because it's one of the first studies. It was prospective. 157 patients, yet they had initial MRI, 3 monthly PSA, and yearly MRI. Only 16% of these patients progressed. Only 12% switched to treatment, and the detection of histological progression was done in 20% by PSA, 50% by multiparametric MRI, so we need multiparametric MRI in the follow-up, and 30% by systemic biopsies. MRI staging and follow-up will become the future management of active surveillance. And this is the last slide. The ASSIST trial, which is another randomized trial coming from Toronto, Laurie Crott presented, and this is very simple result. Systematic biopsies at the inclusion criteria to active surveillance are still necessary. They compare systematic biopsies with MRI-guided targeted biopsies and systematic biopsies. So you need to do also systematic biopsies, not only targeted biopsies. In summary, low risk in active surveillance. MRI helps to better classify patients for active treatment. Active surveillance should only be performed with an initial MRI. If MRI is normal, including PIRAS 3, use PSA density to decide on rebiopsy. In this case, systematic biopsies still have to be performed, and we cannot rely on MRI targeted to exclude patients with high cancer, grade cancers, the ASSIST trial. And then I have another case for you, doctor. And this case is a 64-year-old man seeking for a second opinion for treatment. This patient has PSA of 5.6 now. In 2011 was 3.9, 2012 4.2, 2013 4.5. DRE was negative, EPSS 10, no family history. Arterial hypertension, but is no other common morbidity, is fit. Transrectal ultrasound, 45%, 45 milliliter of prostate, no suspicious area. Dilation of seminal vesicle. The patient came with the report because he had transperineal 24 core biopsies. This is the PAT report. Gleason score 6, 3 plus 3 in 4 out of 24 biopsy core were positive. On the left side, left lobe, 10-15% of core areas were involved with cancer. No evidence of perineural or vascular invasion. And now comes the question to you. What's your recommendation? Active surveillance in this patient or active treatment? Before you answer, I will ask, who will be for active surveillance? One. Tell me, doctor, what's your opinion?
In our country, active surveillance is not a good modality because our follow-up systems is not as secure as in the West.
Okay.
Okay, so you see, active surveillance is not observation. It has got a protocol.
Yeah.
To follow that protocol economically, logistically, and psychologically is very, very difficult.
Okay.
Now, the other thing, you have said this is a template biopsy 24 cores.
Yeah.
We have operated on patients who have had 3+3s and have done RARPs where they have come back as high-risk cancers of 4+5 and 4+4. So there is undersampling in our institution. However, Active surveillance, in my experience in the last 5 years that we have been actually doing radical surgery, active surveillance is out of the window in our institution.
Okay. So
logically, logistically, I may not be correct, but that's the real fact in life.
Okay.
People here don't want to live with the cancer.
That's very interesting, because we wanna discuss about this, because country by country has different modality of treatment. So you go for radical prostatectomy probably, right? Maybe robotics. Okay. How about focal therapy? Nobody, is focal therapy used here in, no. You use it? Which kind of energy you use? Oh, radiotherapy. Okay. Now I go. Your dreams are calling you. You accept or decline. I accept it. I have a recurring dream. It's around 20 years from now, 2040. I am 50 years old. When I was 40, 2030, I had a full genetic evaluation. And they discovered I had 70% chance of developing prostate cancer at the age of 50, 55. The morning of 15 January 2040, I have a multi-purpose whole-body molecular scan and liquid biopsies. This is a dream, of course. 2-hour exam using various tracers, based on the protocol of the 11th International Consensus on Molecular Imaging of Prostate Cancer. 1.5 cc intermediate risk prostate cancer at the apex peripheral left zone is diagnosed with low metastatic potential. Prostate biopsies has been abandoned since 10 years. Specific molecular tracing of pelvic node is negative. Based on global prostate cancer guidelines, which has been endorsed by EAU, I am advised to go for the standard treatment. And this is the standard method. It was 45-minute focal robotic molecular target treatment of the lesion, including 2 millimeters safety margin. I was informed that the chance of cure was 95% at 15 years, no impact on urinary incontinence, no impact on sexual function. Follow-up plan included serial molecular imaging, secondary prevention program. I was a curious person, and I checked the historical perspective of my treatment, and I discovered that in the first decades of 2000, radical surgery included extended pelvic lymph node dissection or radiation therapy plus minus hormone therapy were the standard treatment, with a significant impact on urinary incontinence and sexual life, with possible long-term morbidity. And also, I discovered that the progressive abandon of this invasive treatment was due to the pioneering work of several researchers in the field of basic science, imaging, and energy technology. So, I will discuss a little bit with you about focal therapy, because really I think could be the future. Just go, you just do a genetic test, you are at risk, you do a very, very sophisticated MRI, maybe 22 Tesla, and then you find out a small cancer which has been treated immediately by your radiologist or something like this. Could be the future. And really think this is an interesting field. So I brought to you this small presentation on focal. And of course, tissue preservative strategy has been used, and we use it in renal, thyroid, breast, liver, and pancreas. Why not in prostate? We, of course, have the objective with focal to obtain a good treatment to cure the patient, minimizing morbidities. And the intent to cure with focal is only in low volume, easy targetable patients, tumors. We have another option, the intent of disease control, to prolong natural history and delay morbidity of radical treatment, or focal therapy as part of multimodal treatment approach in high-risk, non-curative intent, aimed to lower the morbidities associated with radical treatment. However, these are the most important questions we have to ask ourselves. What is the ideal candidate for focal therapy? How to localize the disease? How to identify the lesion to target? What is the ideal energy we have to use? How to define success or failure? Functional and oncological outcome, are they good? So we start with the list of energies. Cryo, very much used. HIFU is high intensity focused ultrasound. I'm using this one, and especially focal one right now. Brachytherapy, probably our colleague is using brachytherapy, or laser ablation, radiofrequency ablation, irreversible electroporation. I started with this one 10 years ago, and really was interesting. Or vascular target photodynamic therapy. These are the energies. Any approach able to preserve part of the prostate tissue can be called focal therapy. We can treat an area in a lobe. We can treat only one lobe of the prostate, or we can have hockey stick treatment, one lobe plus a part of the other lobe. This is the definition of focal. However, there are also drawbacks. The first drawback you can tell me is, but dear doctor, prostate cancer is a multifocal disease in 70–80% of the patients. And different foci can have different Gleason score. The concept of the index lesion. The index lesion is the lesion we take and we treat and then we control. But we can have a large index lesion with low grade and a small, very small foci of high grade non-index lesion in the prostate. And the intent to cure is in low volume, easy targetable tumors. Focal therapy, I must be very clear, is not an alternative to active surveillance. No. Because active surveillance is no treatment. If you do a treatment in a patient like this and you have a complication, is very important complication. And legally, probably, now you are in trouble. It would be over-treatment in many patients, as I said, and will be not beneficial. So active surveillance, however, is not perfect. We know that 33% of patients are understage and they progress. So this patient could have radical therapy or could be treated by focal therapy. So this is a table showing you the inclusion-exclusion criteria for focal therapy trials. And the inclusion criteria, that's about PSA, okay, is Gleason score 3+4. Remember, the most trial on focal therapy right now has been done, my trial also in phase 2, in low-risk patient, because we want to know what happens. Now we have to redo everything in intermediate risk patients. So, patient with Gleason score 3+4, locally confined to the prostate, preferably unilateral, may be considered as candidate for focal therapy. Nomogram may be considered to minimize inclusion of patients with nodal disease. And focal therapy should be compared with radical surgery. So, intermediate risk is the ideal candidate. However, we have, in this patient, there is a chance we miss the nodes. Therefore, what has been said would be discussed during the EAU meeting that focal is still investigational. However, even the guidelines recommend is the therapeutic approach with the most important future potential. And what we heard during the EAU meeting this year is focal need to standardization of definition, eligibility criteria, endpoint, protocols for evaluation and follow-up. And the need are randomized clinical trials and mature oncological follow-up data. I wonder whether my dream has any chance of becoming reality. About prostate cancer, localized and advanced. Radical prostatectomy. What emerged from the EAU this year? Delay of treatment with radical prostatectomy. How long can we wait? Everybody has a long waiting list of radical prostatectomy patient. Are we safe? Legally, I mean. And this is a study tried to answer this question. They looked at 1,642 men from Norwegian registries, and they grouped the patient according to the delay in days. 60 days, 3 months, 4 months, 6 months. And analysis for cancer-specific survival was done after 12 years. And 24% had low-risk disease, 36 intermediate, 41 high-risk. And what they found is that delay of treatment of up to for 6 months was not related to cancer-specific survival. So we are safe. This patient can wait more than 3 or 4 months. Another interesting study has been presented this year about the clinical significance of a positive surgical margin. It's coming from Italy, from San Raffaele Institute. They look at 1,757 patients. 61% were PT2 after radical prostatectomy, of course, and 16% of these patients had positive surgical margin. Are they important? They found that 49% of these margins were multifocal, and so these were unfavorable. 51% were unifocal, they were favorable. And the conclusion of the author was that 79% of these patients have no biochemical recurrence, and 96% had no clinical progression after 4 years. Another good news. Then I have another case, doctor, for you. 67, maybe some other, you, just in the middle, you. 60 years, 67 years man, hypertension, otherwise healthy. Initial prostate cancer diagnosis in April 2011. Clinical T1C, Gleason score 3+3 in 4 of 12 biopsies, 10-20% core area involved, PSA 4.9. He had low-dose radiotherapy plus brachy in June 2011. His PS nadir after treatment was 0.5, so was fine. Perfect. However, his PSA increased to 3.1 in November 2013 and 4.3 in January 2014. So he had a trust guide biopsies, and they found 3 out of 12 biopsies were positive for Gleason score 7, 4+3. What you do? What you suggest? Is it right, this one? If you have a patient like this, what's the first step you take, doctor? A microphone, please. There is a microphone here. Where are you from? Calcutta? Okay. And you work in hospital, in university hospital, private practice, whatever? Okay. May I have a microphone there? You can hear this gentleman. Okay. So what? Okay. Okay. Please go on. What you do?
This is definitely, we need to go for this evaluation for, we need this PSMA and PET-CT, which was done. High intraprostatic activity. Is there suspicious locally recurrent? Yes.
He has a, but you do PSMA, PCT, PET choline?
Yes.
You have it? Okay. Okay. So you use it?
Yes.
Because in Italy, for instance, it's very difficult to get it. We have 4 or 5 centers right now, but you know, it's very important. So you agree on this yes. Stuff. And so this was found. High intraprostatic activity suspicious of locally recurrent prostate cancer, no evidence of seminal vesicle involvement, no evidence of lymph node metastasis. So what you recommend?
You should go for the salvage radical prostatectomy.
Salvage radical prostatectomy. Yes. How many of you would say another thing? What you
I would like to just correct, there are 3 centers offering PSMA PET-CTs in this city, and in this country there is very little experience with salvage radical prostatectomy even in the big oncology centers. So most of our patients will be treated by androgen deprivation therapy.
Okay. Salvage radical prostatectomy. This guy
because this is still localized.
Okay.
And so we will have to give a chance for the patient for cure.
Okay. However, these are the data coming from salvage radical prostatectomy. I have a few minutes because I have to close. 395 men operated with salvage radical prostatectomy, 186 with open and 209 robot. Multi-center study presented this year. The severe incontinence at 1 year was 34% in open versus 20% in robotics. 35% in both group had at least one complication. In both group, 10% Clavian dindo more than 3 or equal to 3. So patient must be informed before you do this surgery, because it's not an easy surgery, and it must, patient could have big complication. This is another report from the EAU. 100% of men having salvage radical prostatectomy by a single surgeon reported sign of incontinence. 43% with severe incontinence, 63% reported incontinence before surgery. And the author suggested that, therefore, we assume that especially patients with preoperative incontinence are excellent candidates for undergoing radical prostatectomy, salvage radical prostatectomy. No comment about that. And about after focal, 34 men from Toronto, 46 men from London, and the biochemical recurrence was 21% and 24% after 9 months. And the focal therapy is appealing for patient, but oncological outcome is questionable. So the summary, radical prostatectomy and salvage radical prostatectomy, delays of surgery is possible until 6 months. Positive margins are only relevant if unfavorable, multiple, and more than 3 millimeter. Salvage prostatectomy causes severe incontinence in at least 1/3 of patients, and oncological outcome of salvage prostatectomy after focal therapy is unfavorable. Then I have also this one, but I think I have to close, right? Okay, I thank you for your attention.
Dr. Pradhan from Calcutta, in your focal therapy, what's the scope of adding in your armamentarium this chemical ablation by injecting alcohol or thermoablation by injecting hot water?
You have to repeat the question.
Yeah, in your focal therapy.
Focal therapy.
Focal therapy, the energies you are using, say, X-ray or the
High few.
ultrasound
High
or
few.
like that. But what about chemical ablation by injecting absolute alcohol, or thermotherapy by injecting hot water into the targeted therapy? Injecting absolute alcohol.
Okay.
Chemical ablation.
Okay, like chemical ablation. No,
Yeah.
I have no experience on that.
And also injecting this, or thermotherapy with injecting hot water in the targeted.
No, we don't use that. We use a balloon in the rectum in order to reduce the space.
That is for benign prostate, that we know. But the targeted focal therapy, just
the target. No, I did.
targeted
Okay.
therapy, yeah.
The target therapy. I treat patient in two ways. One was irreversible electroporation, so you have a grid, and then when you do biopsies, you have the biopsies in a certain point, and then you put the needle in the areas. Maybe I didn't understand what you say. And the other way is high few. It's very simple. This is robotic treatment. So it measures the length of the prostate and the thickness of the prostate. So you can modulate what you want to do. Especially you treat one lobe or just an lobe.
No, I'm telling about the energy. Energy means it is the heat energy. Heat energy.
Heat energy.
Yeah, heat energy with hot water.
Yes, I have no experience with heat energy and hot water.
Whether it can be used or not.
I mean, it's not been used yet.
And alcohol, absolute alcohol is used
yes,
it is used for benign prostate hyperplasia as well.
Okay, but it's not.
If it can ablate the prostate benign, I think it should work.
In literature, there is no report of this kind of focal therapy with alcohol.
Thank you.
Next is, I am requesting Professor Sile to have this delivery.
Dear Chairman, dear colleagues, dear friends, it's a great honor for me to be a part of this meeting. And I'm going to try to cover 3 important topics of urology, and which has been discussed during the annual Congress this year. And I'm going to start with the pediatric urology for the beginning. A human rights activist and poet, Maya Angelou, said, "A solitary fantasy can transform a million realities." I want you to look at this picture carefully, because this was drawn in 1921, about 100 years ago, in a French journal. And in this picture, you can see that there is a surgeon sitting on the console and doing the operation with the equipments, which is similar to what we do today's robotic surgery. So when you dream, and it can come true in the upcoming years. Now, we are amazed by what is happening in robotic technology, and sometimes we are getting scared. Are the robots going to replace the humans? We're going to see, but this is not today's task for me. I'm going to summarize you about the robotic surgery in pediatric urology. When we look at the EAU guidelines on pediatric urology, there are 4 topics which has been discussed. The first one is UPJ obstruction, second one is vesicoureteral reflux, complex stones, and ectopic ureter treatment. When we come to the real life, we can extend these indications to a lot of surgeries, but I must admit and say that most of them are overuse and over-treatment. But the most common applications in pediatric urology with robotic surgery is pyeloplasty is the most common. And then ureteral reimplantation, then heminephrectomy and other reconstructive procedures. What are the advantages? We have better cosmesis, and we have better magnification, decreased pain, and decreased length of stay. And of course, when we do with the robot, we have better ergonomics, we have 3D vision, and increased maneuverability. This is showing a nice slide. Those are my patients, which one operated with the open pyeloplasty and robotic pyeloplasty, and after 6 months later, you can see the difference. So this is the history of the robotic pyeloplasty, which is started like 15 years ago. And the guidelines, which is depending on the evidence-based medicine, says that in 2018, robotic surgery has a lot of advantages compared to the other procedures, and with having the same success rates just like the open surgery. You can see the demonstration of open, laparoscopy, and robotic, but whatever approach we choose, of course we are depending on the equipments, do we have those in our institution, but whatever approach we choose, the gold standard technique is Anderson-Hines, dismembered pyeloplasty. This is not comparable with Fengerplasty, non-dismembered options, or endopyelotomy. The gold standard is Anderson-Hines. So let's have a look at the literature. What does the meta-analysis say? This is a nice one published 3 years ago, and this is comparing open and robotic surgery, and this is also confirming what the guidelines say. But the major drawback of robotic surgery is, of course, increased cost and increased operative time compared to open surgery. And this is another meta-analysis confirming this study as well. And this is the study which was organized under the umbrella of the EAU. We have the EAU Young Academic Group, and this is the largest pyeloplasty study ever published in the literature. In this study, we compared laparoscopy and robotic surgery. And what we have found was everything was almost the same, with having success rates more than 95%, but the length of stay was shorter for robotic surgery, and also the complication rate was surprisingly less in the robotic surgery. It was 3% for robot, 7% for laparoscopic surgery. So this is a nice overview and pretty straightforward operation, which is done in one of my patients. He was 9 months old. And what we do here is, it's a robotic pyeloplasty. What we do here is we put a hitch stitch first, and this is giving us the ability to perform the anastomosis in a straightforward way. How many of you have robots in your institution? How many of you have access to robot? Because 1, 2, because I know there are 60 robots in India. That's what has been told yesterday. So what we do here is we cut the renal pelvis. I think when you do it in an open surgery, even this is a debate. Should we excise the renal pelvis, or should we just excise the UPJ? Well, when we look at the literature, there is no significant difference when they come after 1 year post-operative period. So when we cut the renal pelvis, and then we do the spatulation. This is an important part. After the spatulation, we start with the posterior anastomosis. This video has got a little music, if you can open a little bit. So what is amazing for me is the magnification of robotic surgery. So this is 9 months old patient, and you're doing the anastomosis with an enlarged view. And this is increasing the quality of the anastomosis. That's what we believe. So what we use here is 5-0 Vicryl. But in older patients, like after puberty, you can use 4-0 Vicryl or PDS. And after the posterior anastomosis, after putting 3 or 4 stitches, we insert the double J stand in an antegrade fashion. This is also another topic which is being discussed. Should we insert it in an antegrade fashion or retrograde fashion, or should we put an external nephrostomy tube after the surgery. And again, looking at the literature, antegrade stenting has got the least complication rates compared to the others. So finally, after putting the JJ stent, we complete the anastomosis. This is the final view. So the second most common surgery that we do perform in pediatric patients with the robot is ureterial reimplantation. So this is the history of the operation. It was started about 10 years ago in children. There are two types of ureterial neocystostomy. You know, one of them is intravesical and one of them is extravesical. Of course, there are other techniques, but basically intra and extra. So when we look at the Cohen procedure, if you do it with the robot, it's time consuming. You have a narrow space. Think about it. You just get all the instruments into 200 or 150 milliliters of bladder. And also there's limited data in the literature. But when we come to Lichgregor, the extravesical procedure is more practical because you have a wider space. You do it in an intraperitoneal way and you have accumulative data. And it is obvious that in this slide, only 3 publications are there available about the intravesical implantation, whereas we have got numerous publications for the extravesical reimplantation. When we look at the performance of this procedure in the United States, the number is increasing as well as in Europe. But the major question here is, what about the success rate? Are we having the same success rate with the open surgery? We can say yes for pyeloplasty, but this is a subject of debate now, especially in pediatric urology community. So even the robotic pediatric surgeons some of them says that we have less success rate, but some of them say we have high success rate. So this is an ongoing discussion. When we look at the comparison between open and robotic reimplantation, this study is in favor of robotic surgery because you have less length of stay and the pain medication was less, but of course the cost was high and the operative time was longer for robot. In another study, this one says robotic surgery has got 13 points of complication, whereas open reimplantation has got 4.5 rate of complication. So there is no need to perform robotic surgery in this case. There are some technical modifications that I can say which is important because those technical modifications increase the success of this procedure in a robotic fashion. And this is one of our publications published 3 years ago. What we do is we do a top-down approach. We put the first stitch to the top and it elevates the ureter without any tension, and then it facilitates the suturing process. So this is the how we insert the trocars, one through the umbilicus and 2 instruments on the lateral sides, and of course assistant port is optional. And the position of the patient is similar to the robotic radical prostatectomy. So in this video you see a female patient. We are looking at the pelvis, and in this one we are looking at the male pelvis. What we do here is we elevate the ureter when right entering into the bladder. We detach the attachments and then we cut basically the detrusor muscle until reaching the mucosa, and when we reach the mucosa we put the first stitch to the top. So by this way, we have an elevation of the new hiatus at the first stitch. Of course, I'm not doing this surgery this fast, but this is modified in the video. And then we close. We put like 5 or 6 more stitches to close the detrusor muscle. So this is a typical Lichgregor procedure, but in a robotic way, actually. So when we look at the guidelines, what it's saying is RALUR. RALUR means robotic assisted laparoscopic ureterial reimplantation. It is promising procedure, but the current evidence does not routinely recommend and does not support. Only in experience sense, maybe can be offered as an alternative. The technique needs to be optimized. Still, open ureterial reimplantation is the gold standard. What about the future of robotic pediatric urology? You know that the new generation robots are coming. We hope that they are going to decrease the cost and this will increase the numbers of robots in all over the world. And also, the technology is increasing. The single port of the Da Vinci is being launched within this year. As a take-home message, robotic surgery in children is increasingly being performed. Pyeloplasty is the most common procedure, and in the evidence-based medicine we can routinely recommend, if we have in our institution, of course. Advantages increase for reconstructive cases, and it is feasible at all ages. Now we can perform robotic surgery even 2 months old or 3 months old babies, and it is being published in the literature. However, we need smaller instruments, 5mm instruments, and better instruments are required, like better articulation. Another important topic which is being discussed in this year's EAU Annual Congress was the transitional medicine, which Professor Chappell briefly discussed. As you know, that there are some congenital diseases, and we do operate them when they're a child, but when they grow up, the problems can occur. They have physical changes, they have physiological changes, and psychological changes as well. So just to give you an idea, what are those cases? Hypospadias, extrophy, DSD, disorder of sexual differentiation, or in other term, the old term is intersex, cloacal anomalies, neurogenic bladder, and posterior urethral valve. This study was published 2 years ago. We have challenges, we must say. And the challenge of the young person is that he may not be ready to assume responsibility for good urological care when he becomes an adult. And the family has a challenge, and the challenge is they dance between the independence of their child and their responsibility. We, as the urologists, we have challenges. The pediatric team must take the responsibility for an effective transfer to adult facility. And the adult surgeons has a challenge. They may lack all relevant previous clinical information. So basically the transition problems are functional, cosmetic, sexual problems, because when they get older, they want to get married or they sexual intercourse, they want to have a baby, so a pregnancy is another problem. Patient may lose access. Adult urologists are unaware of previous condition and specialized care. So adolescent urologists or transitional urologists are on the rise in Europe. This is a case of hypospadias. He was operated 3 times during his childhood. He came to me after 18 years old. He has got a severe curvature, like 90 degrees of curvature, because the skin is not enough. And also he has got multiple fistula and still having the urethral meatus in the penoscrotal junction. So what we do in this case is we, first the degloving of the penis should be performed, of course. And after degloving of the penis, we have several weapons that we can use to correct the curvature. And in this case, what we did was we put fairy cuts on the ventral aspect of the penis. And after doing these fairy cuts, the penis was straightened. But the problem, the skin was not enough to cover the penile shaft. And in this case, what we get was, with the help of a dermatome knife, we get some nice skin, and then we covered the penile shaft. Of course, we put a buccal mucosa also on the ventral aspect for a second stage procedure. This is the postoperative right after the operation. And this is 6 months later. You can see the buccal mucosa intake and also the graft intake was really perfect. So he was ready for the second stage operation. So those cases, I believe that you have those kinds of cases too. So as a take-home message, adults with operated hypospadias or crippled hypospadias may also have severe curvature. There is no single method for correction of curvature. This is depending upon your experience, of course. You may do a Nesbitt plication too, but consider skin graft, free skin graft, if you don't have something to cover the penile shaft. Cosmetics is on the rise. In this year's annual congress, there were some abstracts, and we are now, the pediatric urologists, more aware of giving a score for the cosmesis. This is one of them, and this is the other one. So if we have a good cosmesis in the childhood, we may have a better cosmesis later in life. Another transition problem is for neurogenic bladder patients. Although the survival rates increased over time, we still have those patients, and they are growing. As you know, that they need lifelong care. Some of them are on the wheelchair. They have several operations, sometimes botulinum toxin injections, sometimes bladder operations, and sometimes major operations just like augmentation cystoplasty. And when you do an augmentation cystoplasty in a 5-year-old kid, when he becomes 20 years old, he may even come with you with a cancer. Electrolyte imbalances, mucus formations, stone formations, I'm pretty sure you see this, and a lot of infections. So lifelong care is required. Another important topic is the cloacal anomalies. This is one of my patients. So you can see there is no anus. Anal atresia. She has got a urogenital sinus. Urethra and vagina are coming together, and we open the colostomy. So we have to think for the future. We don't save the day. We have to think for the future. And to achieve fecal continence, we need to achieve a urinary continence for the future. And when she becomes older, she's going to think about a functional genitalia, of course, like having sexual intercourse, and maybe she's going to ask for having a baby. So I want you to look at this slide also carefully, because this is a resolution published last year in the European Council. And this is about disorder of sex development. As you know, when the patient comes to you with DSD, what we do is we have a genetic evaluation, we counsel the family, and then we do our operation and raise the children accordingly, like a boy or a girl. Sometimes against his or her karyotype. Sometimes he's a boy in genetics, but we raise as a girl because of the phenotype. So in this case, what the European Parliament suggests is surgical interventions are only for emergency conditions. Otherwise, we have to keep this decision when he becomes or she becomes older. But this is just a suggestion right now, but it will affect our current practice, daily practice in the future. This is our pediatric urology guideline panel. Every year, as Chris said, we are trying to update according to the evidence-based medicine. And for the transitional medicine, I'm pleased to say that in the upcoming years, 1 or 2 years, we hope that we are going to have a specific chapter on transitional urology. That is what we talked 3 weeks ago. So what is hot in andrology? Let's take a deep breath, and the rest of this is going to come. For the andrology, of course, we cannot skip varicocele when we talk about andrology. I like this definition a lot. This is a surgeon who was living in the 16th century, and this is the definition saying vascular plexus filled with melancholic blood. This melancholy really gives a good idea about varicocele. So this is an IVF register study, a German IVF register study. You know that when the couples come with an infertility, most of the time gynecologists don't even examine the male and then or underestimate the male factor, and they take them to IVF or ICSI. This is not in general in Germany. I'm pretty sure they're very careful about it, but in general. So, but with the best treatment of IVF and ICSI, the baby take-home rate, here you can see 19.5%. This is really low. So, and when we come to the birth defects, with the assisted reproductive techniques, when they become pregnant, the birth defects compared to the natural fertility are increased. 9% on one side and 4% with the natural fertility. So why am I telling you this? We, guys, we the urologists, should play more important role for the couple's fertility. We need to evaluate them, not only from varicocele point of view, but also the other points of view too. As you know, that varicocele can cause failure of the testicular growth, may cause pain, discomfort, subfertility, hypogonadism, and approximately 1/4 of men with abnormal spermiogram has got varicocele. So we have trouble about telling our patients the necessity of the treatment, and because there's a controversy in the literature, isn't it? And this is coming from a Cochrane review in 2004. In this review, what's being said is there is no evidence that treatment of varicocele improve the couple's chance of conception. Come on, this is Cochrane review, this is the highest evidence. Should we trust this? Yeah, we trusted for some time, but 2 years later, Ficara and his colleagues analyzed the same data, but they used different statistics. In this case, they put on the one side treated and untreated, and what they found was that pregnancy rate was significantly higher in the treated patients, in varicocelectomy patients, compared to the untreated. So this study was revised, and now in the varicocelectomy is being accepted as a valuable operation, of course. There are some other studies showing that it improves the sperm parameters, increases the sperm concentration, and it improves the reduces the sperm DNA damage, and it has an impact, positive impact on ART outcomes. So when you do ICSI, before ICSI, if you do varicocelectomy, you have higher chance of pregnancy. Of course, if the patient has got varicocele, I'm not talking about subclinical varicocele. Another thing is for non-obstructive azoospermia. As you know that we do TESE. Do you do TESE procedure here for ART? How many of you do TESE? 1, 2, 3. So we try to find out the sperms for having a pregnancy, so for ovulation. And in this case, if you do varicocelectomy, and after varicocelectomy you do the TESE, you have a higher chance of retrieving surgically retrieved sperms. Another thing is for adolescent varicocele. In the adolescent period, if the patient has got varicocelectomy, they have a higher chance of becoming a father in the future. So when we look at the guidelines, the evidence is robust. 1A. Varicocele repair was shown to be effective in men with oligospermia and a clinical varicocele and otherwise unexplained infertility. But we have to keep the balance. Do not treat varicocele in infertile men who have normal semen analysis and in men with subclinical varicocele. So this is also a strong evidence. We have to keep the balance. We have good evidence to say that microsurgical varicocelectomy is the best technique to use, and it's superior to the other techniques like laparoscopy or Palomo procedures or embolization. As a take-home message, varicocele may lead to male infertility. We, the urologists, should play more role in the treatment of infertile couples, and it improves many of the parameters to achieve pregnancy. One other issue is the male infertility, which is being discussed in this year's annual Congress. Many things affect male infertility, as you know, like smoking and obesity, but also environment is affecting. This data is really robust. It was published 1 year ago, and there is a significant decline in sperm quality. And in this study, 180 studies were collected and meta-analyzed, and what they saw was, when compared to 1970 and when we come to today's years, there was a 50 to 60% decline in the sperm quality. And the most disturbing thing was that there were no signs of leveling off in the upcoming years, so the decline is going to continue in the upcoming years. So what can be the cause? Endocrine disrupting chemicals was hardly being discussed. But what is this? They are in plastic bottles, they are in everywhere. In metal food cans, detergents, toys, cosmetics. We call them BPA, PCBC, and phthalates, heavy metals. But what they do basically is they mimic the female estrogen, they antagonize the androgens, and they can pass the placenta, and of course they can influence on the testicular development. There are a couple of studies showing that those endocrine disruptors affecting fertility, this is the LIFE study, and what they found, they measured the blood and urine, and in patients, in men who had got higher levels of endocrine disruptors, then the couple fecundity, the ability to achieve pregnancy was decreased. Another study, EARTH study, also looked at the birth weight. So this is not only affecting fertility, but when the patient, the family has got pregnancy, this is also decreasing the birth weight. Another study, SEED study, In this case, they looked at the patients who are going IVF treatment, and in this case, the quality of the blastocyst stage of embryos were also decreased in men who has got higher endocrine disruptor levels. As a conclusion, endocrine disruptors may have influence on male infertility, and high levels of them in further negatively affect the fetus, and it is time to take action globally. Maybe we have to ban the plastic bottles, or maybe some of the perfumes, I don't know. When we come to endourology, I think this is your topic, guys. You are very experienced in stone disease. I really know that because this is an endemic area, just like in Turkey, just like in Pakistan, Iran, we have a lot of stone patients. So, you know Michelangelo, he's an Italian artist and painter. What does he say? Every block of a stone has a statue inside it. It is the task of the sculptor to discover it. So what's been learned from this, as a urologist point of view, removing the stone surgically is never enough. It is the task of the urologist to find out the composition of the stone. Come on, guys, we are not technicians. We remove the stones, but we forget the stone analysis. Starting from myself, and we forget metabolic analysis. So we have to keep it carefully, and this is according to the recommendation of the guidelines. Look at here. Perform stone analysis in first-time stone formers using a valid procedure. And this is a strong recommendation. Another thing being discussed in this year's Congress was medical expulsive therapy. Should we do it or not? When we look at the 3 years ago in Lancet, a very nice study published, it was saying no. Don't use MET. But when we come European urology, in this year, in this study, they used tamsulosin, alpha blocker, for medical expulsive therapy, and this says yes. And in this study, I want to look at this picture. If the stone inside the ureter is larger than 5 millimeters, and if you give tamsulosin, like an alpha blocker, and this is increasing the spontaneous passage of the stone. So you won't need a surgery. When we look at the evidence, again, we can also offer a medical expulsive therapy for stent-related symptoms. If the patient has got a stent inside of it, you can use an alpha blocker. What are the treatment options? We have got ureteroscopy, flexible, retrograde intrarenal surgery, every types of PCNL, and we have got combined procedures like laparoscopy or robotic surgery. We can combine many of them. For the ureteral stones, we can use ureteroscopy and shockwave lithotripsy, of course. And there is a nice summary of evidence in the EAU guidelines for using the technique. So if you have time, I encourage you to look at this carefully because there are high levels of evidence. There is one thing which is being discussed was the single-use flexible ureteroscopes. Many of us has got flexible ureteroscopes that we use maybe 30 times, 50 times, depending on our experience. But the single-use flexible ureteroscopes are now on the market, and this is, has got low risk of urosepsis. You use it maybe one time, but after that you can use it maybe 5 or 6 times. And now it is becoming more economically available because of the increasing numbers. It has got high flexibility. Here you can see that even when the holmium laser inside of it, he has got a good flexibility. And you can see the image here. It's almost like a digital scope, huh? It's not like the other scope. Of course, PCNL is one of the most important procedures that we do perform for the stones larger than 2 centimeters. And when we look at the miniaturization of percutaneous nephrolithotomy, it's going like crazy. First, it started with mini PNL, then ultra mini. Ultra mini is from India, it's from Janek Desai. And also super mini is from China. Micro perc, I don't know if you have it. Also, this is from India. And this is 4.8 French, which is 1.6 millimeter. Can you believe? Just you get inside the needle, you break the stone, and then go back. So the miniaturization means a lot. It increased maneuverability inside the kidney. It has a less tearing of the renal parenchyma. There's a reduced risk of bleeding and reduced length of hospital stay. How many of you, what is the current process that you use? Mini PNL in your patients or standard PNL? How many of you has got mini PNL? Yeah, almost all of you. So when we come to microperc, this is the smallest available tract. It's a promising technique, but the major problem is the visualization, because the pixel number is low, lower than the flexible ureteroscope or percutaneous. It's 10,000. And ultra mini PNL, as I mentioned, is like 13 French. It's a standardized equipment. So this is a pretty straightforward mini PCNL procedure performed in our institution. Most of the time, we puncture to the lower callus. Dilatation is necessary, of course. You need to dilate in between 15 French or 20 French, depending on your scope. And then nephrostomy tube, sometimes we put, sometimes we do not. If there is no bleeding, if you come inside with the 14 French, maybe you don't use a nephrostomy tube. And this is effective on large stones. You know, there are two types of reaching the stone: eye of the needle technique or triangulation. Most of the time I use eye of the needle technique. And the other procedure is microperc. In this case, you have a direct puncture to the stone, and there is no dilatation is required because you just get inside with 4.8 French. There is no nephrostomy tube, and it is effective on small stones. You just insert the needle, break the stone, and then go back. The major drawback of this is you cannot take out the stone. So it is important for the children and also for adults too. So after the procedure, you don't need to put anything on it. It's just like putting something over there. But again, another problem is the intrarenal pressure, guys, because there is no amplas sheet, and when you do the surgery, you always give inside the irrigation, you increase the intrarenal pressure, but there is no water coming out. And this may cause complication. We published this study 4 years ago. We compared conventional PCNL and microperc, and significantly higher levels of pressure was inside the renal pelvis when we do with microperc. Guys, this is one of my case. We performed microperc for 1 centimeter of stone. We get inside in the prone position. There was no problem. I completed so it was stone free. But when we turned the patient in a supine position, the patient was distended. Why? Because of the increased intrarenal pressure, because we pushed the paddle so hard, the irrigation was going, and then an intra-abdominal extravasation occurred, and we need to put an intra-abdominal drain in this case. So we have to be careful about when we are giving the irrigation. Yeah, we do have a ureteral stent, but even this was an infant patient, so maybe this was the reason. Just even small amount of irrigation may cause a problem with the renal pelvis. Another thing is laparoscopic surgery or open surgery. This is the last slide that I'm going to show you. We still have option in anomalous kidneys, just like pelvic kidney stones or horseshoe kidneys. We can use laparoscopy because in those cases it is sometimes impossible to perform percutaneous nephrolectomy or flexible. This was one of our case. Again, this was a pelvic ectopic kidney stone which we did not be able to go with the flexible ureteroscope. And in this case, this is a laparoscopic procedure, and we are inserting microperc under the guidance of laparoscopy. So we can always combine the procedures according to the equipment we have and according to the experience we have. You need to use fluoroscopy. Laparoscopy does not avoid you to use fluoroscopy. And when you find the stone, you just fragment this with a holmium laser. It's a pretty straightforward case. As a final message, stone analysis should be performed in all cases, and MET alpha blockers are recommended in distal ureteral stones. Miniaturized PCNL decrease the complication rates, and optimized treatment should be chosen according to the patient and stone characteristics. I also invite all of you for next year Congress in Barcelona, and thank you very much for your attention.
What is the scope of premarital semen screening before marriage?
Sorry, say it again?
Premarital semen screening before marriage, so that those who have, say, oligospermia or azoospermia should have treatment before they go for marriage.
Well, you know, infertility is a clinical issue. Sometimes the patient has got oligospermia or astenospermia, but they can achieve pregnancy. So in any case, when we look at the guidelines, you do need to try like 1 year of period of coitus, and then if you do not achieve pregnancy, you go for treatment.
Yeah, but you see in India, our marriage, say more than 50% or 60%, it's a arranged marriage, not like Western countries.
Okay.
So what is happening? Because after marriage, they are sort of they come for infertility treatment. And now the misunderstanding comes between the partner, between the parent families, and if the semen analysis is done before the marriage, so that they can find out whether this boy is fertile or not.
That's
then
right, but to be honest, that's a good question. Routine semen analysis before marriage is not necessary, but if the patient comes to you, even 14 years old with, or 15 years old, with a large varicocele, with the symptoms, and it's recommended to give a semen analysis, if he can give, of course. But otherwise, there is no routine use of semen analysis.
No, because this is a big issue in India. That's why in India they are mushrooming all those fertility clinics.
That's right. Thank you very much.
Okay, dear colleagues, I'm really sorry I'm now standing in between you and the final game, but I'm the last one and I'll try not to do too much unless this thing here comes off somehow. Okay, thanks a lot. Okay, my goal is to show you a little bit about the best what we can extract from this year's annual meeting in Copenhagen on urothelial and renal cell cancer. This is not my wife, this is the symbol of Copenhagen, the mermaid. Now, I'm really happy that members of the scientific committee, which I'm chairing, really contributed with their souvenirs at the end of the meeting to this talk and to what I'm going to present to you. It's Maria De Santis. She's an oncologist Oliver Grimm, a colleague from Germany, and Morgan Roupré from Paris. Now, these are my conflict of interest disclosures. I just want to point out that the biggest meeting which we have within the EAU, and one of the biggest in urology worldwide, is the annual Congress. As has been said, it has not only a lot of participants, but during those 5 days we have an enormous amount of sessions, both invited, thematic, plenary sessions, as well as free contributions, and many colleagues, we are really happy, from India also present there and are there contributing. Now, we'll talk about urothelial cancer and renal cell cancer, and then in urothelial cancer, we'll just tackle the non-muscle invasive versus the muscle invasive and the upper urinary tract urothelial cancer. Now, one of the things is when you talk about bladder cancer, we are still lacking a good imaging, a structured imaging, an imaging that is allowing us to, in a nice way, prospective way, see how we can use imaging. And MRI has been the best imaging for staging bladder cancer, as we know. Now, there is also a way of doing multiparametric MRI using contrast material, and there's been very nice contribution that has shown that the multiparametric MRI, similar to the multiparametric MRI in prostate cancer, can also be structured in bladder cancer as well. And there we don't have the PIRATs, but we have the VIRATs. And this is going to come, and it's going hopefully to help us in the future. Now, the other thing is, imaging is one thing, but the bigger hope in bladder cancer, as we all know, are tumor markers. And tumor markers, we are in a way fortunate in bladder cancer that we have urine going around the tumor or being in contact with the tumor cells directly. And so we can try to extract information from there, such as the mini-chromosome maintenance proteins as possible markers, and see whether we can use that either in a screening. Screening is very difficult in bladder cancer, more difficult than prostate cancer, because the incidence and prevalence is too low, actually, to do a meaningful screening so far. But at least to show in a risk population whether the proteins in the urine can be thus used as a tumor marker. And it's been very nicely shown by this group that there is high hope that these proteins, because they represent an arrested differentiation, and thus are different from the normal hyperplasia epithelium in a way that it allows us to use as a urine marker. The other one, it has been used, and you can see here that the sensitivity is reasonable. It is getting better in the intermediate and high-risk patients. So those are the ones which we actually need to find earlier. Those are the ones that we should not miss, and especially in the high-risk non-muscle invasive bladder cancer with a 92% sensitivity. It is something that allows us to have at least big hopes. There's another one, the bladder EpiCheck, which has been used also. We have used it together with Fred Wittjes and presented this year in Copenhagen the data. And it looks like in the monitoring, this was not for the for a screening purpose or for diagnostic purpose, but for monitoring patients with bladder cancer, so that we may be able to increase the intervals between one cystoscopy and the other, because I think you're all aware and you all have those patients that eventually tend not to come because they don't like cystoscopy that much. And so there is something where we may work on with a test like this, maybe together with ultrasound or maybe with other imaging modalities to substitute that. We're doing now in Germany a prospective multi-center randomized study looking at not only this test but all tumor markers, including sonography of the bladder, to see whether we can, in a prospective way, show that at least in the low grade, we may then substitute these markers for some of the cystoscopies. And you can see here, especially in the non-TA low grade, you can see that actually this is having a very good performance. Those are the ones which we need, the non-low grade TA, the one that are more aggressive, the ones where it's really dangerous. We are all more interested now in the complications and how we deal with the complications. And so we have now, for the last two congresses, included more and more complication sessions. And one is in the plenary, the nightmare session, where we have not only the complications and the discussion about the complication, but we have also included a lawyer. You may be fortunate in India not to having so many lawyers like in the US, but in Europe we're facing that problem increasingly. We don't have that many lawyers in the US yet, fortunately, but we're also facing that problem. So we have, with the help of Tim O'Brien, now included a lawyer that really during that session discusses things like perforation during a TURB and subsequent problems, at T0, at cystectomy, and complications during robotic cystectomy. Very different aspects from a lawyer. He sees it totally different. We say at T0, okay, you can be grateful, you're cured. We took your bladder out, but that's not a problem. But that is something that is completely different seen by somebody who really wants to get on your neck, such as a lawyer. I'm not, I mean, lawyers, some of the lawyers are my friends, but just to have that, and we'll continue to do that during the upcoming meeting. One of the things is complications. We are trying to grade the complications. You know, you're aware of the Clavian-Dindo, two surgeons who have tried to grade the post-operative complications. Post-operative. But there is intraoperative changes and complications. And now it's been, this group has very nicely made a proposal of a classification of an intraoperative adverse incident classification, so that we can also see, for example, you go into a surgery, you try to do a partial nephrectomy, but eventually it turned out you did a nephrectomy. So that is a change. It may be a 1 because it was necessary due to the tumor. But it may also be that the problem lied that you got the wrong side of the kidney. That's possible. I mean, it shouldn't be possible, but as we know, it has happened at least in the literature, you find cases. And so then you have that classification. Okay, now from the urothelial non-muscle invasive bladder cancer, let's go to the muscle invasive bladder cancer. And there we have the topic now that's still present or is coming more and more is how much robotics can be used during cystectomy, during the advanced surgery of bladder cancer. And the CORAL trial from the UK was a prospective randomized study that looked at in a prospective randomized fashion, the differences between open, robotic, and laparoscopic cystectomy. Open versus robotic versus laparoscopic. Very nice study, small numbers, but as we all know, a prospective randomized study in that setting is really, really difficult, and it's really difficult to persuade the patient that he should not decide, he or his relatives shouldn't decide, and you shouldn't decide as a treating physician, but it should be randomized. So that study, which initially was showing that there were no more, there was no difference in positive margins, in survival, and of course there were some problems with statistics due to the small numbers, but it has been at least a good indication of what we see now and what this French multi-center study has shown, which only looked at open versus robotic. And what they have shown in more than 250 patients is something which we have seen in other studies as well: lower median blood loss, lower blood transfusion rate, and reduced median hospital stay, and even little less earlier major complication postoperatively. That being said, the RAZOR trial has shown that all that may be, but the soft tissue margins actually were statistically significant more often in a robotic cystectomy. And that is worrisome. Because I'm not saying that any of this should lead us not to do it in a robotic fashion. Cystectomy should not be done in a robotic fashion, but it does have its downside, and it's something which we definitely have to focus. Maybe we have to apply different techniques. Maybe we have to do a better selection if we do these patients, because a positive margin in bladder cancer can mean death to the patient. From an oncological side, this is definitely something which is much worse than a positive margin in radical prostatectomy. So something which you have to look at. There was a nice talk from Das Gupta, who said the robot is an unnecessary luxury in the developing world, and the cost of the robot led to additional healthcare costs, additional costs because of the procedure. And we have to think that there will not be, at least not in the healthcare system I come from, there will not be more money going into urology. There will not going to be more money for bladder cancer unless we show that the numbers are rising extremely. But if we use additional costs, or if we have additional costs, it has to come somewhere within urology. So there may be something that will then, where the money is missing. I'm just bringing this one up. This is the saying, you know, it's been quoted a couple of times: a fool with a tool is still a fool. So a good surgeon who is doing open cystectomy may be more advisable than a beginner with a robot. But the only thing which we have to think about is definitely one thing: the robot can do better teaching. And so for the next generation, the robot could be or will be beneficial, because the learning curve is lower, and you can show your residents or your young colleagues every step of the procedure, and you can do it in a leisurely way. So that is something which we have to think. Just to tackle very shortly is galanine. When we do any pelvic surgery, be it us as a urologist, be it the gynecologist, be it the general surgeon, we are interfering with nerves there. We are interfering with the autonomic nerves and also with the sensory afferent nerves. Different topic, but we cannot, from an oncological standpoint, do a nerve preservation in all cases, and we definitely cannot do 100% nerve preservation. So for that reason, these papers are really important, that we find something like galanine to administer that and being able to restore the function that actually come out from this severing of these nerves. And galanine may be one of the possibilities which can be maybe in the future used for the reconstruction or the restoration or regrowing of these nerves. One of the problems which we have is not this guy who is maybe Croatian or French. It's the perioperative chemotherapy. If urothelial cancer of the bladder is not organ confined, we cannot cure this patient in 50%. 50% is not curable if it's not organ confined. But the problem is perioperative chemotherapy as a possibility to the additional, rightly correctly cystectomy as the major treatment, but still, if we cannot cure it in the non-organ confined disease, we need more. But still, approximately 30%, according to the latest figures, do get perioperative chemotherapy. More in the adjuvant than in the neoadjuvant setting. I'm not going into that discussion right now, but there is a problem. We need that. We need more possibilities. Now, neoadjuvant versus adjuvant, we can have the whole evening discussing that and the pros and cons, and there is very scarce literature. There's one paper, it's a Millikan, the old paper, it's more than 10 years, 15 years old now, almost 15 years. It tried to show adjuvant versus neoadjuvant chemotherapy in a randomized fashion. Slightly better for the adjuvant, but it wasn't meaningful with those numbers. And there was in the last ESMO, the European Oncology meeting, they also looked in very small numbers in the perioperative chemotherapy, and you can see here actually that the that the adjuvant chemotherapy was actually slightly better in the overall survival to the preoperative, but it was definitely both were better than doing giving no perioperative chemotherapy. Now, part of that problem is that the chemotherapy which we use, which is usable, is the cisplatinum-based chemotherapy. If we cannot give cisplatinum, which is in the older population, which we have in bladder cancer, is a problem. If we cannot give that, then it's not really that effective. And so the cisplatinum-based chemotherapy now may be replaced with the new advent of immune checkpoint inhibitors. We have decades-long experience in urology with immunotherapy, starting with BCG, IL-2, and so on, and interferon and further. But now with these immune checkpoint inhibition, where we try to block the tumor's defense mechanism. The tumor has a defense mechanism. It defends the T cells that are upcoming to kill the tumor cells. It defends it by a checkpoint inhibition, by checkpoint ligands. And by inhibiting that, we can get the T cells to the tumor. So it gets through the armor of the tumor cells. And that, not only that, we also have the possibility to have less side effects. I wouldn't say no side effects, but less side effects. And with that, and a meaningful application, either prior to a cystectomy or after cystectomy, we can probably get it better for the benefit of the patient, included in our armamentarium of the aggressive invasive tumors. And you can see here the checkpoint inhibitors are correctly now in many studies applied, and many studies examined right now, both in the non-muscle invasive as well as in the muscle invasive as well as in the metastatic disease. One of these papers was by Briganti and Necchi from Milan that looked at the neoadjuvant immunotherapy prior to cystectomy. And very nice study. You look at there is actually a shorter period of time where you use systemic therapy prior to a cystectomy. So that is already an advantage, because usually you give 4 cycles of cisplatin gemcitabine, and that takes 4 months. And here we're trying to reduce that to 9 weeks. The only thing in that study is, well, they claim they have less side effects, but if you look here at the side effects, what worries me is if you look here to the right column when it says postoperative complications, and I do not see a type of postoperative complications. I do not see a 32% sepsis in my patients after cystectomy. So I am a little bit worried that with those checkpoint inhibitors, some of the patients may have some other problems which we are not aware, which we will become aware. Anyhow, that is for neoadjuvant. Adjuvant chemotherapy using cisplatin now also gets a higher level of evidence that it may be beneficial if we take into account just a recent study from Sternberg looking at the adjuvant therapy, chemotherapy. Now, urothelial cancer of the upper urinary tract, we had very nicely Birtle from the UK presenting a prospective randomized study looking at the perioperative chemotherapy of upper urinary tract renal cell cancer. A very nice study, very important, because it did show that if you give it within 3 months after a cystectomy in patients with positive nodes and or in muscle invasive or periureteral or perirenal infiltration, then if you give that, the patients do have a significant benefit in survival, and that is something where I think we are having really an advantage now, and this is definitely going to be part of the guidelines, of the upcoming guidelines, because a disease-free survival is definitely increased by almost 20%. And so definitely it is a problem. If you look at here, it is especially in those patients that did not have nodal involvement, that had gemcitabine cisplatinum, a better renal function, and that were negative for their margin status. So it's surprising that actually the better patients benefited more from the perioperative chemotherapy. Something which we have also seen, by the way, with the lymph nodes trial, the LEA trial, the extent of lymph nodes in bladder cancer. There was last year's EAU in London, where the data were presented for the first time, and that has shown also that the T2 apparently have a better benefit from an extended lymphadenectomy. What I'm getting at is we have to rethink that sometimes those that are prognostically better, they may benefit from a more additional treatment. Now, when it comes to chemotherapy for urothelial cancer, we usually tend to give 5 to 6 cycles of gemcitabine cisplatinum. Now, that's given in patients that may have a problem with their renal function and also have hyperacusis. They have a hearing problem. Now, cisplatinum, apart from the renal problem, may also increase the hearing loss and peripheral neuropathy, something that may lead to a social diminution of the quality of life in these patients. And Necki has very nicely shown that if you reduce from 6 to 4 cycles, 2 cycles less, you could say 1/3 less of cisplatin exposure, that these patients have the same effect from their chemotherapy, but with less morbidity. And the palliative chemotherapy thus should be reduced in 4 cycles. Now, when we look at the new immunotherapeutic agents, we have for the palliative or for the metastatic disease, we have now 5 new drugs coming up that, at least in Europe, atezolizumab, pembrolizumab, and nivolumab have been approved for the secondary cisplatinum refractory bladder cancer, first indication. The second is 2 of those drugs have been approved for the cisplatinum non-fit patients, those where I told you those are the ones that are really not benefiting from systemic therapy. And there are 2 other ones, durvalumab and avelumab, which are coming up and which will most probably show in urothelial cancer also a benefit. So it's exciting times, and we'll hear more about it at the next meeting in Barcelona. And we see also that we can apply this also, for example, pembrolizumab in patients that are older and patients that have a less ECOG cancer, ECOG general status. Now, okay, let's move from the urothelial cancer to the renal cell cancer. Again, imaging, ultrasound screening for renal cell cancer is cost effective. And this is something which should make us urologists proud, because we are the ones that can do ultrasound screening in a meaningful, effective way, and we are not in the claws of the radiologists with their MRI and the enormous cost explosion that would entail. So it is cost effective, and we should do it. We should do it, especially in the patient group between 60 and 75 or 55 to 70. That is the age range where screening with ultrasound for renal cell cancer makes sense, and you should do it, and it is for the benefit of the patient. What about renal mass biopsy? It seems to be effective, but this is too small numbers to really make any recommendation. Now, this was the last goal the Germans did during this championship. At least it was a nice one. It showed precision, and that's what I'm getting at, yeah? Because that precision is necessary to do a partial nephrectomy. Because if we want to get a partial nephrectomy, we don't want to get the ball outside the goal or onto the post of the goal. We want to get it in. And so there were very nice several papers in this year's meeting to show how we can make robotic partial nephrectomy or any partial nephrectomy more precise. One is 3D virtual reconstruction of the renal vasculature, and thus having less global ischemia, and also use near-infrared fluorescence imaging. So we are approaching partial nephrectomy for the non-ischemic, for the elderly patients, or for the patients that have already a compromised renal function. The other one is you can try to do preoperatively an embolization, and not doing an embolization, that's an old thing, but also to include with the embolization some dye. So when you open it up, you can see with the dye the actually embolized area, and thus be faster in taking it out. So it makes it a nice, fast procedure. And the third one is the robotic partial nephrectomy using indocyanine green. That is something that has been used in ophthalmology, and it shows nicely the base you may better differentiate between the tumor and the normal kidney. One of the things, we have those semi-live sessions now. One surgeon with his video clips, no sound, no nice music, nothing, but the surgeon with his video clips and 3 people on the panel that sometimes give him shit, but they really make a discussion. And one of these was the robotic radical nephrectomy with vena cava inferior thrombectomy. As you can see here, you start out with the kidney, and then you really temporarily clamp the vena cava, and then excise the thrombus. So that is a possibility. I wouldn't advise you to start out with that, but it shows that it seems that the limits of laparoscopic and robotic tumor excision go even further. At least it is a possibility. Now, one of the definitely highlights was the analysis of the adjuvant targeted therapy in the adjuvant setting for high-risk renal cell carcinoma. You know, you always have to weigh high-risk renal cell carcinoma, but you don't see any metastasis. There's no evidence of metastasis. Should you give him targeted therapy and have the patient deal with all the side effects? And maybe 50% don't need it. 50, 60, 70% won't need that, and they will just have the side effects. And the healthcare provider will only have the costs. And it's been shown that actually there is no real benefit in the overall survival, and it's the disease-free survival is most probably not beneficial either. So currently this cannot be supported. What is nice is if you look at the recurrence pattern of renal cell cancer patients, within the first 5 years, definitely most of the recurrences are in the lungs. If you go to the recurrences after 10 years, it's less the lungs, it's more the bones and the other organs. And so you have different patterns, and this may be different for you when you look at it. Now, does sunitinib alone, or does sunitinib followed by immediate cytoreductive nephrectomy or deferred nephrectomy make a difference? Well, it makes a difference with regards to complications. Sunitinib may increase the bleeding, and therefore the increased bleeding may then lead to a more complication rate if you're doing it too early. If you're going later on, if you have more than 3 months after the sunitinib treatment, after finishing the sunitinib treatment, then the grade 3 and 4 adverse events are lowered. So that is definitely a benefit. Now I'm getting to my last 2 slides. One is the changing landscape of advanced renal cell cancer. You can see here every decade has its changes with regards to renal cell cancer. And you start out in the 80s with the cytokines IL-2, interferon alpha. That's where we got our experience with immunotherapy in renal cell cancer. And then in the 80s, in the 90s, it just started to change, especially then when the new targeted therapy came up, and sunitinib, sorafenib, bevacizumab, bazopanib, axitinib. Now all are substances which we use, including the mTOR inhibitors, temsirolimus and everolimus. And now in 2010, the whole thing changed again with the advent of checkpoint inhibitors, nivolumab, ipilimumab, atezolizumab, and now pembrolizumab. They all came, and now what we are seeing is the combination, and that is the next thing. We're going to see the combination, and those are the currently ongoing studies where they try to have in first and second line the TKI, the checkpoint inhibitors, and the cabozantinib and other drugs upcoming. It's a little bit confusing, but on the other hand, it gives us a nice armamentarium. Last thing is what about cytoreductive surgery in the metastatic disease? Unfortunately, it seems that in the high-risk patients, the CAMINA trial, which has just been a month ago or 6 weeks ago has been published, has shown that actually cytoreductive nephrectomy in patients that are highly metastatic and high-risk patients does not seem to be beneficial. So that is something which we have to really rethink. But the jury is not out. I'm not saying that all metastatic disease should not have a nephrectomy for several reasons. The low volume metastatic disease may benefit from that, and the other thing is we may need information about the primary tumor. both from the type of histology as well as the genetics. Having said that, I just want to conclude. I wanted to show you that urinary tumor markers in urothelial cancer, robotic cystectomy, and checkpoint inhibitors in urothelial cancer, that is currently the focal points, as it seems, in the changes that we are going to face. And in renal cell cancer, again, it is robotics, but it is also the checkpoint inhibitors that are really beneficial. Now, I just want to show you how the gynecologists in Germany work. As a last thing, it's a very, very serious thing. You can see here the gynecologist looking at a pregnant woman, and of course, you know, he's calling in one after the other. You know, it's really serious, extremely serious, you know, as you can see. Everybody's really worried about. Terrible. And the lady, she's really worried too. But they try to keep her down. And then finally, you know, at the very end, they have the solution. They made a goal. So enjoy tonight's football game. Thank you very much.
Thank you. I'm afraid we misinformed you. We thought it was starting the match at 9:30. Apparently it's starting now. So we're going to go straight to this, and we'll take questions over supper and after the match, okay? So I think we're going to put the match on the main screen. Is that right? Thank you very much indeed for my colleagues and for Lupin for supporting this. But Arnulf, that was a great talk. Maurizio, fantastic talk. And the same, of course, from Professor Selu. Thank you very much. Apparently it's 8:30.